industry too. And there are many things that Dr. Ahmed, honestly, I just get surprised when you go to meetings. There is always a surprise for me. And I'm sure that there will be one today. Dr. Ahmed.
Thank you, Prof. Hatoun, for the introduction. I'm really humbled with your amazing words as usual. And it gives me great pleasure to be with you here today. And after spending a beautiful 3 years with the Ministry of Health, or even more, it gives me great pleasure to be talking with you today about the Human Being Day and looking at the redefinition of the well-being in inherited blood disorders. I've prepared a couple of words, not a presentation. It's more from the heart than something that is educational, because when we often speak about inherited blood disorders, the language is hemoglobin levels, transfusion schedules, admissions and readmissions, treatment protocols. They matter, and of course they do deeply matter. But today, I do believe they are no longer enough. The vision is beyond that. For decades, we've defined success in the inherited blood disorders when it comes to disease control and the evolution in disease control. But what does it really mean to truly live well with an inherited blood disorder? At the Ministry of Health, we believe that well-being is not just the absence of complications. However, it's the absence of limitations, the presence of dignity, resilience, autonomy, and hope. A patient can be clinically stable, yet emotionally exhausted, adherent, yet disconnected, alive, not yet fully fulfilled. So we have Muhja, and we're glad that we have been able to launch it last year with a lot of partners and a lot of support on global, national levels, with the presence of international federations like the World Federation of Hemophilia, Thalassemia International Federation, local support and huge support from Sultan bin Abdulaziz Humanitarian City, the presence of our local patient organizations, and it was truly a dream coming true. We have beautiful ambassadors, which we have one of them with us today. So, from disease-centric to human-centric approach, from episodic care to lifelong support, it's time to enable possibilities beyond just treatment. Well-being is the context that really means the whole human being. And we believe that stories do matter, and you've seen in our exhibition a couple of stories being heard and seen in videos and in voices that explain their stories, and we want that to cope with the future and the presence of AI. And please, let me turn this with you into stories in motion. And with that, we're pleased today to announce one of our initiatives, which is Stories in Red, which is not just an add-on, but it's an extension of really believing with the patient empowerment when it comes to well-being. Through the responsible use of AI in this era, we are not replacing the patient voice. We are amplifying it, preserving it, and allowing it to educate, inspire, and connect across borders and generations. Stories humanize data. Stories build empathy, with which statistics, I do believe, cannot do the same link like stories do. Today is not about replacing clinical excellence, it's about complementing it. And as we move forward together, local, global experts, organizations, and patients' communities, we do so with one clear conviction. Inherited blood disorders will be always in our heart, and they are not defined by limits. Today is the time to go beyond the limitations of any disease. I will leave you now to the video of Stories in Red, and hope you enjoy the initiative that we're planning for our upcoming awareness days planned in April, May, and June for hemophilia, thalassemia, and sickle cell disease, respectively.
Some stories are written in red. Stories of people living with blood disorders. Real lives, real struggles. Stories that deserve to be seen and heard. In line with Saudi Vision 2030 for digital health and medical innovation, and at the IHBD Summit 2026, where science meets humanity, we are proud to introduce the Mohja AI Film Award, Stories in Red, a creative journey unfolding across 3 stages. In each stage, 3 winners will be crowned for Best AI Film, Best Human Story, and Best Creative Use of AI. April's theme is hemophilia, May, thalassemia, and June, sickle cell anemia. We look for storytelling, accuracy, and impact. Visit our website to view the criteria and join us. Because awareness begins with a story. Stories in Red, where innovation meets humanity.
We're really looking forward to take this initiative to reality now. And one of the beautiful experiences that we have is a live experience with us today, one of our ambassadors. If I start talking about him, I believe I need another presentation to give all of the details, but I'll leave this pleasure to Dr. Hatoun and Prof. Hatoun to give the introduction of our eminent ambassador and to enjoy the upcoming presentation with him.
Thank you so much, Dr. Ahmed. I have to be very honest. I happen to know about Mohja AI Film Award just last night. So he prepared the surprise very well. But please do encourage your patients. It's not necessarily patients, it's patients, caregivers, physicians, healthcare providers, anyone who wants to come and enjoy the new version of the Joy Film Award. It's the Mohja AI Film Award, so we're happy to kick off this as of today. It gives me really a great pleasure to present our ambassador. I'll do some presentation in English, but I have to switch to Arabic as well. Ustad Ahmed al-Dosari, Ustad Ahmed al-Wadani al-Dosari. Since we started Mohja and before Mohja, I found this guy coming and talking to me. And since then, every single day, there is a message from him, not to ask, not to say anything, except prayers for me and my kids. أستاذ أحمد يرسل لي تقريبا كل يوم على الواتساب مش الدعاء المكتوب, not the written. Actually, he films himself either standing in Mecca, Haram, ولا in a holy place. Just now we met at the exhibition hall and he said, there is no enough word to say about you, but what I've done right now in this corner, I prayed 2 ركعات and I was praying for you. قابلته في الإكزيبيشن هول وقال لي ما أعرف إيش أقول, ما حتكلم عنك, لكن كل اللي سويته قال صليت 2 ركعتين ودعيت لك. Since this has been happening, I got a call from him just before Hajj. This year for me, or past year for me, was the first time experiencing Hajj work. So we've been in Mecca, we gathered our stuff and we stayed there for a month in a certain area. We have our special cars, you can't really move, you have the uniforms. And then this guy called me and he said, I want to go to Hajj, I'm going to Hajj. And I want to do something with you. And honestly, it never crossed my mind. So what we did, we went to the registry, we looked at the biodata because each Hajji has a license for Hajj, and we merged, and he helped us to find that from the registry there are 146 patients with sickle cell thalassemia hemophilia performing Hajj last year. And he said, I want to do something for patients. I'll leave you with this video. Just it speaks how of a beautiful heart, a human he is. يعني صدقا ما في كلام يوفيك حقك. يعني أنا بقول لهم من أول يوم حتى من قبل أنا ما أجيك أنت بتجينا. جيتني قبل الحج وقلت لي أبغى حج وإنه بنعمل شيء للمرضى، ورحنا بسبب بعد فضل الله سبحانه وتعالى اكتشفنا إنه في 146 حاج طالعين. رجعنا للسجل الوطني وعملنا الحركة الجميلة اللي في الحج. Please start the video because I don't want to take too long and I want to give him lots of time to talk to us.
سعيدين اليوم بتواجدنا معاكم في مبادرة مهجة Ministry of Health Joint Association، المبادرة الوطنية الشاملة للجودة الصحية لأمراض الدم الوراثية. مهجة اليوم أصبحت حجة Health Authorities Joint Association، وهي الخدمات الصحية في الحج بامتياز. اليوم نعرفكم على سفير مبادرة مهجة أستاذ أحمد الدوسري، وهو مريض هيموفيليا أو نزاف، بيتلقى العلاج المفروض إلا المريض الهيموفيليا ياخده قبل الحج، ويعطي بعض المعلومات المفيدة عن المرض لسلامة الحجيج من مرض الهيموفيليا. أستاذ أحمد دوسري، السلام عليكم ورحمة الله وبركاته.
ورحمة الله وبركاته، حياك الله دكتورة.
أشكرك، وحج مبرور إن شاء الله مقدما بإذن الله بصحة وسلامة وإنسانية.
من الأشياء الأساسيات في العلاج إنه يكون حافظ عليه من خروجه من المنزل حتى توصل مكان المشاعر المقدسة. يكون في شنطة خاصة تبريد علاجك، الكرتون فيه كل الإمكانيات المعقمات، اللهم تاخذ قرفز معك. هذا الأمر الأول. الأمر الثاني إنه يكون قبل ما تتحرك من المنطقة اللي أنت فيها للحج، يكون الدكتور المباشر على علم ودراية بأنك تنطلق الحج، يزود بعض المسكنات وكمية من العلاج، وتقرير طبي يقدم للجهات المختصة في المشاعر المقدسة.
نعم.
الأمر الثاني تأخذ جرعة قبل الذهاب إلى مكة، وتأخذ جرعة إلى جرعتين لا يقل عن جرعة أو جرعتين أثناء أدائك للمناسك. ويكون على إلمام المستشفى، العيادة نفس الحملة يكون فيها عيادة، يكون على إلمام بوضعك الصحي.
نعم.
مبادرتكم هذه سهلت طريق طويل على الحجاج المرضى. خلاص متابعة مباشرة من مهجة وزارة الصحة مع المريض أول بأول، اتصال مباشر، توعية وتثقيف لهذا البرنامج. أسأل الله الحمد. الآن أنا خذيت قبل ما أنطلق قبل 3 أيام من منطقتي من الرياض، خذيت علاج، وبكرة عندنا يوم التروية يبدأ مناسك الحج، يحتاج لجرعة بعد الطواف، تمتع، ازدحام، لا أحتاج الآن جرعة عشان إن شاء الله أمسك المناسك بكل سلاسة.
طبعا مرضى الهيموفيليا معرضين للنزيف في المناطق اللي عليها ضغط أكثر، في مفاصل الكاحل، مفاصل الركب، مفاصل الورك. فالسبب الرئيسي من أخذ الاحتياطات قبل ما نبدأ إنه نعزز عوامل التجلط لمنع أي نزيف في المفاصل بإذن الله، أو نزيف في أماكن أخرى.
So believe it or not, Mohja was born April 17, 2025, and this guy made Mohja as young as the baby to be Hajja, which is the Health Authorities Joint Association, but this time A+ with excellence, بامتياز. So honestly يعني أنا بقول لهم إنه بعد الله سبحانه وتعالى، برغم إنه مهجة بيبي صغيرة اتولدت يوم 17/4، بعد فضل الله سبحانه وتعالى أنت خليت مهجة حجة. طيب. Now I would like him to come to the stage. Something just to tell you about too. ما شاء الله ما شاء الله ما شاء الله لا قوة إلا بالله. Mr. Ahmed Al-Dosari received his gene therapy and he's off factor for the past 4 months. ألف مبروك، الله يتمم لك على خير ويكفيك الشر بإذن الله. So after 50 years of receiving factors, that's an impressive news, and we're very happy for him. Ustad Ahmed, تفضل.
السلام عليكم. السلام عليكم. السلام عليكم. السلام عليكم ورحمة الله وبركاته. أسعد الله صباحكم جميعا. غير السلام عليكم ورحمة الله وبركاته. أسعد الله صباحكم. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا ونبينا المصطفى صلى الله عليه وسلم. قال النبي صلى الله عليه وسلم: من لا يبدأ بسم الله الرحمن الرحيم فهو كاذب. فأول شيء أقف أمامكم كل فخر وأوفيكم من الله سبحانه وتعالى لأني أتحدث باسم كل لسان بطل من أبطال أمراض الدم. أنا ما أمثل نفسي أحمد الدوسري، لا، أنا أمثل كل بطل من أبطال أمراض الدم، وأتحدث باسمهم وأتحدث بمشاعرهم وأتحدث بكل ما يكون في حياتهم العملية والعلمية والنفسية. اليوم جعلوني أشارك مهجة، ما يحتاج أتكلم عن مهجة، بس جعلوني أشارك بمحاضرة بسيطة أنقل لكم البيئة اللي يحتضنها البطل من حياته، من بداية حياته حتى ما وصل إليه هذه الفترة. بدايتي أشكر المملكة العربية السعودية على إتاحة الفرصة في استضافة هذه القمة الرابعة، على رأسها وزارة الصحة والقائمين من كل المجالات على إنجاح هذه القمة، وما شاء الله تبارك الله ناجحة بجميع المقاييس. ثانيا أعرفكم بنفسي. أحمد الدوسري، أبلغ من العمر الزمني 50 سنة والعمر النفسي 20 سنة. بتوفيق الله سبحانه وتعالى تم ابتلائي بهذا المرض. بداية أي بطل يحتضن والديه طفل، يفرحون في البداية أنه جاهم مولود، ولكن بعد اكتشاف أن المولود مبتلى بمرض من أمراض الدم، يعني ردات الفعل تختلف من شخص لآخر. ولكن لله الحمد والمنة، والدي علما أن والدي لا يقرؤون ولا يكتبون، ولكن علاقتهم بالله سبحانه وتعالى طيبة. فبدأت رحلتي مع الهيموفيليا منذ طفولتي، حين اكتشف والدي أنني مصاب بهذا المرض النادر. أتكلم عن 50 سنة. كانت المعاناة مشتركة، فهم من وقفوا بجانبي في كل لحظة ألم، وكل زيارة طارئة للمستشفى، وكل جلسة علاج طويلة. تحملوا القلق والخوف وكرسوا حياتهم لرعايتي وتوفير العلاج اللازم. أتكلم عن العلاج النفسي، وكانوا مصدر قوتي الأول بعد الله سبحانه وتعالى. رحم الله الوالد، وأعان الله سبحانه وتعالى، ووفق الله الوالدة بصحة وعافية. التحديات والعمليات. للمعلومية، ما أدري أتكلم في أحد يترجم كلمات خارج النص. دكتور أحمد، للمعلومية، كانوا والدي كل ما أصبت في البيت، في المدرسة، في الشارع، كل ما أصبت يقابلون إصابتي بابتسامة، يودوني المستشفى، أجلس 5 6 10 ساعات، والله الابتسامة لا تغيب عن محياهم، بل يضحكون معي ما كأني أتألم، ولا كأنهم ينتظرون هذه الساعات الطويلة مراعاة لنفسيتي. تفضل المايك.
Something that Mr. Ahmed was really grateful for is the presence of his family members, his parents, and how they supported him through his journey. Whenever he had an injury, it was never a limitation for them to stop them from giving him the opportunity to enjoy his life. They didn't mind spending hours and hours in the hospital with him, with a smile on their faces, to give him always the right support to keep moving on and keep enjoying his life. And he believes that that really contributed massively to the way he dealt with the disease and the way he looked at his life, and how the psychological support and emotional support that he got from them was beyond any medication. Especially, he's talking about the disease that was discovered 50 years ago. So the treatment options were not, of course, even close to what we're seeing today. However, their emotional support was a game changer for him and the way he led his life accordingly.
A very summarized translation. His parents taught him what does a smile mean during pain, which is something really we don't know how to do it. But this is what he had learned from his parents, is how to smile during pain.
شكرا دكتور أحمد، شكرا دكتور هتون، ولا زلت أحتاجكم. تحديات والعمليات، كثير من المرضى أبطال أمراض الدم يصيبهم ما يصيب أي مريض من آلام وإصابات، بعضهم يدخل إلى العمليات. يعلم الله سبحانه وتعالى دخولي للعمليات كانت ابتلاء، ويعني محنة لا أنساها ما حييت، ولكن الفضل لله سبحانه وتعالى قبلت هذا الابتلاء برأي والدين. هذا أمر يحصل لك وأنت أفضل من غيرك، ولابد تكون عندك فأل طيب، حياة سعيدة. دولتنا الرشيدة تقدم ما تقدم من إمكانيات حتى صرت تتأقلم مع المرض مثل مريض السكر. موجود العلاج خلاص حياتي أصحاء. فتأقلمت وأنا طفل إني ما دام موجود العلاج توفره الدولة، أنا مثلي مثل أي مريض صحيح متعافي. العلاج موجود، أنا طيب وبخير، أنسى أني مريض.
During Mr. Ahmed's journey, he had several visits to the OR, and only God knows how tough it was, how challenging it was. However, with the support of his parents, they always gave him the reassurance that he's even much more fortunate than many others across the world. With the medications being present and the solutions for whatever challenges he's facing are there, they were able to give him the essence of living with hemophilia as if it was diabetes, with all of the pain that he's going through and all of the challenges that he went through. He was really grateful for that. They always reminded him how to be grateful. The medication is available, and with your mentality and the way you look at the disease, it's as simple as any other chronic disorder that you might face. And that's how he was able to really believe in something like that and move on, paving the pathway in his life with this kind of belief in himself and the support that he's getting from his caregivers and his parents.
مرت سنوات وأنا أتنقل بين مستشفيات. كنت في هجرة، انتقلت إلى المحافظة عشان المستشفيات. مرت سنوات وأنا أتنقل بين مستشفيات، أواجه الألم بشجاعة. خضعت عدة عمليات، وكل واحدة منها كانت اختباراً جديداً لصبري وقوتي. تعلمت أن أبتسم رغم التعب وأن أقاوم رغم الخوف. كانت صور المستشفى شاهدة على لحظات الانكسار، ولكنها أيضاً وثقت لحظات الانتصار. وهذا اللي أنا أعيشه في حياتي حقيقة. أدري كل ما حصل لي نزيف، كل ما حصل لي إصابة، أدري أنها لعلها خيرة، لعلها خيرة. والله أني أرى النور بعد هذا الأمر. آمنت بالله. جاءت مرحلة الزواج. بعد أن تزوجت انتقلت المعاناة إلى مرحلة جديدة، لكنها لم تكن وحدي هذه المرة. زوجتي كانت سنداً حقيقياً تتابع حالتي، تذكرني بمواعيد العلاج وترافقني في كل خطوة. أصبحت شريكة في التحدي والدعم والأمل، بدرجة أنها تحضر علاجي وتحقنه بالوريد. وجودها بجانبي جعلني أواجه المرض بثقة أكبر، وأشعر أنني لست وحدي في هذه المرحلة. حتى في سفرياتي تتواصل معي بشكل مستمر، لأني أنا لا ما أعيش لحالي، أنا أعيش لأجلها وهي تعيش لأجلي. فهي ما تسمعني، حصل لها ظرف ما جات، ولكن أشكرها وأدعو لها في كل ليلة وهي في محلها، تستاهل. نقطة التحول: في أحد الأيام قررت أن أكون أكثر من مجرد مريض. أردت أن أكون صوتاً لكل من يعاني بصمت. بدأت أشارك قصتي، أكتب، أتحدث، وأدعم جميع مصابي أمراض الدم. شعرت أن تجربتي يمكن أن تكون مصدر إلهام، وأن الألم الذي مررت به يمكن أن يتحول إلى رسالة جديدة. قبل 12 سنة مشيت على المرضى، أسأل عن المرضى وين أماكنهم، وأزورهم في أماكنهم، بل بعضهم أقابله في المستشفى وأخذ رقمه، إن كان صغير طفل أخذ رقم ولي أمره. كونت مجموعة مقارب يمكن 40 شخص ولي أمر، أعطيهم تثقيف نوعي وتوعوي لهم لكي تهون عليهم ردة الفعل أن ابنهم لازم يعيش حياة الأطفال. صار التواصل أوسع، صاروا يسألوني كمستشار، ولا ما عندي شهادة ولكن عندي خبرة. صرت أوصل لهم بعض الرسائل النفسية الداعمة لهم حتى يوصلوا للمستشفى. أصيب الولد أقول الحمد لله، إصابته بسيطة، تواصل مع الدكتور أسرع وقت، بحيث أن التواصل هذا يهدي أعصاب الولي الأمر. هذا قبل 12 سنة، حتى وصلت إلى الآن أكثر من 300 مريض يتواصلون معي مباشرة. وفي يوم لا ينسى تم اختياري سفيرا لمهجة. شعرت أن كل ألم مررت به لم يكن عبثا، أصبحت رسالتي واضحة، أن الهيموفيليا لا تعني نهاية الحياة بل بداية رسالة. بدأت أشارك في فعاليات توعوية، وأمثل صوت المرضى في المحافل، وأحمل مسؤولية نشر الوعي بكل فخر. من خلال دوري كسفير أصبحت عنصراً فعالاً في المجتمع. شاركت في حملات توعوية، نظمت لقاءات تثقيفية، وكنت جزءاً من مبادرات إنسانية تهدف إلى تحسين جودة حياة المصابين بأمراض الدم. أصبحت جزءاً من التغيير، وصوتاً للأمل، ويداً تمتد لكل من يحتاج الدعم. مهجة اختصرت جهدي 12 سنة في لقاء واحد. مهجة أظهرت كل ما يحتاجه مريض أمراض الدم في وقت قياسي. يعني توفيق الله سبحانه وتعالى. الفكرة اللي كانت في بالي سبحانه وتعالى قيض الله لها أناس اسمهم مهجة. بعض مشاركاتي في المجتمع سواء في أعمال المحافظة، هذه أحد زيارة توعوية، كنت ألقي محاضرات توعوية في أحد الجمعيات، هذه جمعية أيتام إنسان، وهذه أحد لقاءاتي في مدريد. المرحلة الذهبية هي مرحلة اختياري كسفير لمهجة من قبل دكتورة هتون والدكتور أحمد. في خضم هذا التحول الصحي مرحلة عراب الرؤية ولي العهد الأمير صاحب السمو الملكي الأمير محمد بن سلمان حفظه الله. دور وزارة الصحة لا يخفى على الجميع ما تقدمه وزارة الصحة قبل والآن وبعد في توفير كل احتياجات وإمكانيات للمرضى. تقوم وزارة الصحة في المملكة العربية السعودية بدور أساسي في تقديم الرعاية الصحية للمواطنين، وتشمل مسؤولياتها توفير العلاج في المستشفيات والمراكز الصحية. ذكرت المراكز الصحية لأنها تعطينا تحويل للمستشفى مباشرة، أنها كهجر وليس محافظات. بعد ما انتقلت للمحافظة انتهت الآلام والمعاناة. وضمان وصول المرضى إلى الخدمات الطبية اللازمة دون تأخير. مرحلة العلاج الجيني تكلمت عنها الدكتورة هتون، ولله الحمد من أوائل ما تم اختيارهم في التجربة السريرية أخوكم الواقف أمامكم أحمد الدوسري، ولي ولله الحمد 4 أشهر لم آخذ علاج خلال 4 أشهر، علما قبل العلاج الجيني كان كل أسبوع آخذ لي جرعة وقائية. بحمد الله وتوفيقه تم منحي علاج العلاج الجيني كأحد أحدث العلاجات الجينية المخصصة لمرضى الهيموفيليا بي، وأسأل الله يجعل فيه الشفاء التام ويكتب لي ولجميع المرضى تمام الصحة والعافية. مهجة أظهرت برنامج يحتاجه الصحيح قبل المريض، ولكن فبركة جميلة من مهجة، طريقة جميلة وصلت ما يحتاجه المريض بمراحل أو بعناصر أساسية. سموها برنامج 90 يوم، تعاملون نفسيا تغذويا رياضيا بالتعاون مع مدينة سلطان الإنسانية. وبهذه المناسبة أشكرهم على متابعتهم وحرصهم بشكل أسبوعي مع المريض مباشرة، كأن المريض يتواجد معهم يوميا. فلا زلت في 90 يوم، خلصنا تقريبا 2 إلى 1 و3 أسابيع، ولله الحمد وجدت فائدة يعني لا يعلى عليها من ناحية العلاج الطبيعي، من ناحية الآن أقف أمامكم ما كنت أوقف أكثر من 5 دقائق، الآن خلال 1.5 أو 2 أوقف فترة طويلة ولله الحمد والمنة بعد هذا البرنامج. رحلتي في الحج تكلمت عنها الدكتورة هتون وأحرقت علي الفيلم، ولكن أبدعوا، وأسأل الله سبحانه وتعالى أن توصل هذه الرسالة لجميع المرضى. الخوف عند المريض أمراض الدم كيف يروح للحج، وتعرفون أعباء الحج، ولكن مهجة يسرت كل صعب في مناسك الحج. الفيديو نفس الفيديو اللي ذكرته الدكتورة هتون، وجودي بين الحجاج كان رسالة لكل مصاب: أنت قادر، أنت تستحق، أنت لست وحدك. الأمل مستمر. اليوم أحدث فرقا، وذلك بدعمي والهم الذي أحمله للمرضى وأهاليهم. رحلتي مع الهيموفيليا لم تكن سهلة، لكنها جعلتني أقوى وأقرب، الخط شوي تغير، وأقرب إن شاء الله وأكثر إيمانا، بل لأمل دائما موجود. وكل صورة من صور رحلتي هي شهادة على أن الإرادة أقوى من الألم، وأن الإنسان قادر على تحويل المحنة إلى منحة. شكرا لكم، والسلام عليكم ورحمة الله وبركاته.
Always when we see Mr. Ahmed al-Dosari, this is amazing. مرة شكرا، مرة
جزاك
شكرا.
الله خير.
We always see another a junior ambassador with him, Fahad al-Dosari. Fahad. Fahad, I asked him this morning, do you have iPad or laptop? And he goes, no, I only have phone. And his dad replied that even the phone is controlled. But now I'm challenging Ahmed to go and get iPad or a laptop for Fahad. So
شكرا دكتور، شكرا مهجة، شكرا دكتور أحمد. بارك الله فيك.
Just something to mention. So yesterday the Vice Minister on the way out, because he knows Fahad, he gave him his prayer chain, and he asked them actually to keep the prayer chain until his wedding day, because the Vice Minister had promised Fahad, inshallah بصحة وعافية, he will attend his wedding.
آمين. يستاهل. شكرا دكتور، بارك الله فيك، بارك الله. شكرا دكتور. السلام عليكم.
So our next stop in our well-being journey will be a beautiful session presented by Ms. Arij. She will be speaking with us on the physical rehabilitation across the lifespan, enhancing function and quality of life in hereditary blood disorders. It gives me great pleasure to introduce Ms. Arij today. She's one of our eminent speakers and coaches who are leading the journey of the 90 days program. And one of the things that I really wanted to translate when Mr. Ad-Dusari was on the stage, he was really emphasizing on the role of the physical rehabilitation, and that today, even if he's in his 50s, he's able to walk and stand for much longer periods, exercise in a way and live his life from a physical perspective that he was never able to live before, even in younger ages. And he always extends his gratitude to the team of Sultan bin Abdulaziz Humanitarian City on their amazing efforts through the weekly sessions that he's taking across the three major pillars of Muhja in his journey. Without further ado, Ms. Arij is a physiotherapist at Sultan bin Abdulaziz Humanitarian City in Riyadh, specializing in musculoskeletal rehabilitation and multidisciplinary patient care. She holds a master's degree in physical therapy for musculoskeletal disorders and has clinical experience across pediatric, cardiac, ICU, and outpatient settings. Ms. Al-Thubayt is also a published researcher and actively participates in professional education and physiotherapy awareness initiatives. It gives me great pleasure to have her with us today, and please take the stage.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. My name is Arij Al-Thubayt, physical therapist at Prince Sultan bin Abdulaziz Humanitarian City. And today I will be presenting to you rehabilitation across the lifespan, enhancing function and the quality of life in hereditary blood disorder. We're going to ask ourselves, first of all, why rehabilitation is important for these patients. Hereditary blood disorders such as hemophilia, sickle cell disease, and thalassemia are conditions associated with recurrent bleeding, pain, anemia, and progressive joint and organ damage. Hereditary blood disorders are lifelong and often progressive. Recurrent bleeding, pain, and anemia lead to reduced mobility, fatigue, joint damage and disability, muscles weakness, reduced independence and participation. Also, rehabilitation is essential for preventing secondary complications by maintaining joint range of motion, improving muscle strength, and enhancing joint stability. Early and continuous rehabilitation has been shown to reduce the development of chronic atrophy, arthropathy, deformities, and long-term disability, especially in individuals with a bleeding disorder. Rehabilitation also promotes functional independence and participation in education, social activities, structures exercise, and functional training improve endurance, balance, and confidence, allowing individual to maintain active and productive life. In addition, rehabilitation addresses pain management and psychosocial well-being. Therapeutic exercise, patient education, and coping strategies helps to reduce chronic pain, anxiety, and depression, improving treatment adherence and self-management. For our rehabilitations guidelines, international guidelines emphasize that rehabilitation should be initiated early and continued throughout life using multidisciplinary, patient-centered approach. Also, programs should be individualized according to the age, disease severities, and functional status, with a strong focus on prevention of joint damage, regular functional assessment, and patient education. Collaboration between hematologist, physical therapist, occupational therapist, and psychosocial, dietitian, and professional is essential. Early and life-going rehabilitation. Rehabilitation should be begin as soon as the condition is diagnosed, continuous throughout life. Early intervention helps prevent joint damage, muscles weakness, and functional decline, especially in children with a bleeding disorder. Individualized and patient-centered care. Rehabilitation program must be tailored to individual based on the age, disease, joint involvement, functional limitation, and personal goals for the patient. Patient-centered setting, goal setting improve adherence and the outcome. Preventing for the joint damage, a major guideline focus on preventive of musculoskeletal complications through a joint protection strategies, strengthening and pre-articular muscles, safe physical activities, and early post-bleeding rehabilitation. Regular assessment and monitoring, ongoing assessment of joint range of motions, muscles strength, pain, functional abilities, and the quality of life recommended to monitor disease progression and adjust rehabilitation plan accordingly. Usually we use outcome measures for these patients. One of them is 6-minute walk test, time up and go, range of motion reassessment throughout the rehabilitation program for each patient. Safe and supervised exercise. Exercise should be encouraged, but prescribed and supervised by a trained professional. Rehabilitation should be coordinated with medical treatment to minimize the bleeding risk while improving strength, endurance, and joint stabilities. Education and self-management. Patient and family education is essential and should be included recognition of early bleeding sign, joint protection technique, and safe active guideline, pain management, and self-care strategies. For our rehabilitation intervention, we usually do range of motion exercise, strengthening exercise, balance and coordination training, aerobic conditioning. For the range of motion exercise is to maintain joint mobility and prevent contracture. Strengthening exercise targeting pre-articular muscles to protect vulnerable joint. Balance and coordination exercise to reduce fall risk, practically in adults and older adults. Aerobic conditioning, adapt bleeding risk to improve cardiovascular endurance and overall fitness. Also, we have pain management intervention, therapeutic exercise for pain and improve joint function. Modalities we use such as heat and cold therapy for acute pain relief. Also, we have activity pacing and education to prevent overuse injuries that will lead to the pain. Exercise recommendation should be supervised, progressive, and individualized exercise are recommended. Exercise should be coordinated with medical treatment, for example, factor replacement in hemophilia to minimize bleeding risk. Activities may include swimming, cycling, walking, and low-impact resistance training. For the exercise recommendation, physical therapists to provide instructions on joint protection technique, including correct posture, body mechanics, and movement strategies during daily activities. These techniques reduce mechanical stress and vulnerable joint and help minimize pain and recurrent bleeding. Education on activity pacing and energy conservation enable patient to balance activities and rest, practically in condition associated with fatigue such as sickle cell disease and thalassemia. This approach reduces overuse injuries and improve participation in daily life. Also, we have the home exercise program. Education is emphasized to ensure correct technique, adherence, and safety. Patients are instructed on when to stop exercise and seek for medical attention, promoting long-term self-management and improved functional outcome. Overall, patient education enhances adherence to rehabilitation, reduce complications, significantly improve the quality of life in individuals with hereditary blood disorder. Physical therapy produces significant short and long-term physical and psychosocial outcome, leading to improve the quality of life across the lifespan. Improved joint and health and structural integrity. Recurrent bleeding, as we all know, episodes are commonly affect synovial joint, leading to a chronic inflammation, cartilage destruction, and hemophilic arthropathy. Physical therapy interventions such as a range of motion exercise, strengthening, and post-bleeding rehabilitation helps to preserve joint mobility, reduce joint stiffness, and delay joint degeneration. Strengthening a pre-articular muscle decrease joint loading and protect vulnerable joint, resulting in better structural integrity and functional movement. Also, for the rehabilitation outcome, we will be having enhancing balance and gait mobility, improving functional independence for each patient. For the balance and gait mobility, chronic joint disease and muscle weakness impair balance and gait, increasing the fall risk. Balance training, proprioceptive exercise, and gait training improve postural control and movement efficiency. These interventions are practically beneficial for adults and older individuals with cumulative joint damage, improve functional independency. Physical therapists enhance the ability to perform activities of the daily living, as we all know, ADLs, such as walking, stair climbing, and also dressing, lifting, functional training, improve task performance, and reduce dependence on caregivers or assistive devices, promoting autonomy and self-confidence. Enhanced participation and social integration. By improving physical capacity and confidence, physical therapy enables individuals participate more fully in education, employment, recreation, and social activities. Increased participation reduces social isolation and stigma, often associated with the chronic illness. Improve psychosocial well-being. Fear of bleeding, pain, and movement often lead to anxiety, depression, and avoidance behaviors. Physical therapy promotes positive movement experience, reducing kinesiophobia, and improves self-efficacy. Those psychosocial benefits significantly contribute to improve the quality of life and the treatment adherence. Also, we have increased muscles, strength and endurance, muscles weakness due to pain, inactivity, and fear of movement is common in patients with hereditary blood disorder. Progressive strengthening and functional training increase muscles force production and endurance, providing better joint support and reducing mechanical stress. Aerobic conditioning improves cardiovascular capacity and reduces fatigue, practically in individuals with the chronic anemia. Also, for the pain reduction and symptoms control, chronic musculoskeletal pain significantly impact daily function and and the quality of the life. Physical therapy contributes to pain reduction through therapeutic exercise, movement re-education, activity pacing, and joint protection strategies, reduces pain, enable to increase participation in rehabilitation and daily activities, breaking the cycle of pain in activities and disabilities. In conclusion, a lifespan-based rehabilitation approach acknowledges the functional needs are dynamic rather than static. In early life, for the rehabilitation, establish healthy movement patterns and build physical confidence. As individuals mature, rehabilitation adapts to increase physical demands, supporting safe activities, work participation, and self-management. In later life or later years, rehabilitation focus on preserving mobility, preventing any secondary complications, also and maintaining autonomy. This continuity of care is essential in reducing cumulative disabilities. In conclusion, rehabilitation across lifespan is essential component of comprehensive care for individuals with hereditary blood disorder. Through early, individualized, and multidisciplinary intervention, rehabilitation not only improves function, but only enables individuals to live fuller, more independent, and more meaningful life. Thank you so much.
Thank you, Ms. Arij, for the beautiful presentation and very informative one. I believe now it's time to go beyond physical to mental health and inherited blood disorders with Ms. Amani Salami, which is a person that I really do enjoy her presentations, me and the patients also. Throughout the awareness days, she was able to frame for us how to look at the inherited blood disorders from a mental perspective and a psychological perspective, and how it plays an integral role in managing, I do believe, all of the other pillars that we would be looking at. Ms. Amani Salami is a licensed clinical psychologist and researcher at Sultan bin Abdulaziz Humanitarian City in Riyadh. She works with interdisciplinary rehabilitation teams, providing neuropsychological and psychotherapeutic care for patients with brain and spinal injuries, while also leading well-being programs and burnout research for healthcare staff. Ms. Al-Salami is an active researcher, lecturer, and mental health advocate with published work and experience in organizational well-being and positive psychology. Please welcome with me Ms. Amani to the stage.
Assalamu alaikum. This is Amani Salmi, clinical psychologist. Thank you, Dr. Ahmed, for the great introduction. Well, from the title, we will talk about the beyond the physical and the medical aspect of blood diseases. We will talk about the psychological burden in inherited blood diseases and why the mental health is a critical part of the care. In common clinical practice, bleeding, transfusion, pain, complications can be effectively treated and managed, but the psychological impact often got unnoticed. Depression, anxiety, stress directly influence treatment, adherence, pain, perception, hospital visits, and long-term outcomes, which mean mental health shouldn't be an optional when treating patients. It is an essential part of the clinical care. Well, we'll first review the global and Saudi studies. This is, let's go to the, and then we're gonna talk about the psychological risk factor and challenges, red flags including suicidal risk, and finally we will talk about how to integrate mental health and multidisciplinary care. Globally, the evidence was found to be consistent in several studies, and these are a few of the meta-analysis studies and systematic review studies within the past 5 years. In hemophilia, a large meta-analysis study showed that 41% of the patients reported depressive symptoms, 14 diagnosed with depression, and around 40 have combined anxiety and depression. In sickle cell disease, quality of life showed lower than the control group, and in also a thalassemia study, systematic review consistently show ongoing psychological distress, especially in emotional and social functioning. Going to Middle Eastern and GCC regions, they are included in this table, although it's remained limited, but the data have found to be equally concerning. as the global studies as well. From the key findings, patients reporting anxiety and depression and lower quality of life. Mental health is a major unmet need, especially in adults and teenagers. Psychosocial stressors significantly associated with treatment outcomes are worse in patients with a frequent transfusion comorbidity, while higher education considered as a protective factor for the patient. The key message from the studies that we can get is that the psychological burden is predictable and hopefully in the future can be modifiable as well. Across the studies, same psychological risk factors appear to repeatedly, which amplifies anxiety, depression, sleep problems, and negative thinking pattern with the patient. Resistant pain, frequent hospital visits contribute to mental health issues, including depression and anxiety. Life limitation, reduced daily activities and social participation lead to emotional distress and reduced quality of life as well. Also, the high cost of treatment imposes significant financial stress on the families, impacting their psychological well-being. Caregiver stress, they also experience substantial emotional and physical strain. Social isolation, especially in youth, particularly prone to social withdrawal due to mobility challenges and stigma. From the factors that we see as well as lower education and income and limited job opportunity for the patients. The challenges where the patients face difficulty maintaining their performance in work or going to universities and schools due to their health constraints. Also, the limited access to medical care as well as the availability of mental health services. We as a psychologist, we use different psychological strategies depending on the patient's needs and the severity of the symptoms. Our role as mental health professionals are using psychotherapy approaches in IHBD care, for example, using cognitive behavioral therapy, building psychological resilience, coping skills with the patient. Also using behavioral activation can be integrated with rehabilitation as well. We can use also pain management technique and, for example, mindfulness, relaxation, and other approaches, including the family and the social circle with the patient. Our role with the multidisciplinary team is to discuss with them, to collaborate with the team as well, to address both physical and emotional aspects of the patient care. And also, as we talked about pain management, it shouldn't be from only one side, but with the team of care, patient got improve and report a better pain management. When we see a patient in the clinic, we do assessment and we do a structured interview to do a diagnosis for the patient. We use ISD and DSM-5, and especially we focus on mood disorder because it's common with the chronic illnesses. This approach depends on the patient's self-referral and clinician referrals. But many patients may not recognize their distress and they have poor insight. They can minimize their symptoms or avoid mental health services due to stigma. The point is, this highlights the crucial part and role of medical staff as the first line of detection to identify at-risk patients and facilitate timely psychological support, bridging the gap before a professional or formal referral. So what red flags can be noticed during the primary care services? For example, emotional red flags, it can be verbal and can be facial when the patient experience or reporting any hopelessness or death wishes, it is considered as a red flag. Also, mood swings, behavioral changes. Physical and somatic cues, sleep disturbances, or explaining some kind of somatic symptoms without any medical causes or reasons. Treatment adherence. They can miss the appointments, they will not be compliant on medication as well. These are from the important signs. Abuse and neglect as well, especially in geriatric patients and children. Unexplained injury, fearfulness, and signs of poor care and hygiene. Lastly, the social withdrawal of the patient is socially isolated, avoiding any social activities, daily life activities. It is a red sign. Suicide risk among IHBD patients, there is an increased risk as other chronic illnesses, but still limited data on suicide rate among IHBD patients. So what can medical staff do? There is a call to action, and the action step for medical staff is to stay alert to these psychological warning signs, initiate supportive conversation about mental health, make it easy for the patient to feel that it's normal to talk about mental health. Also psychological first aid, which we'll talk about in next slide. Referrals for at-risk patient to psychologist and psychiatrist. Also work in a comprehensive multidisciplinary team to ensure a holistic care. The psychological first aid is a specialized training target non-mental health professional who are at the first point of emotional support when someone is in distress, including the healthcare staff, nurses, physicians, caregivers, family, patient association staff and volunteers, teachers and school counselors. They are also can be trained on these kind of skills. And the main principle in the psychological first aid is to look and listen with empathy, acknowledge the emotion that the patient is having, how to respond to the patient with empathy and not sympathizing. It's really important for the patient to open up during the clinic or with any interaction at home, school, and hospital. To be calm and supportive, normalizing the feeling without judgment is very important as well. Assess the need, identify emotion and practice practical need, the fears that the patient have, future concerns that he have. For example, if he have concerns with his illness, for example, bleeding in the future, how he can go to work and university. This is also an important things to do, is making a case conceptualization of all the factors and the things that the patient found it as limited. Connect, encourage follow-up with the psychosocial services and peer support which need a referral sometimes. Also empower the patients, reinforce the strength and coping abilities to focus not only on the weaknesses but also focus on the strength of the patient. Concluding the session with recommendation is to how to integrate mental health in the future. Is regular psychologist screening can be done and can be trained. Not only psychologists can do this, but briefly any medical staff can be trained to do this. And also if needed and if the patient is at risk, they can do a clear referral, but we need a pathway for that in every facility. Mental health training for healthcare provider, as we have mentioned, it is psychological first aid. Improve accessibility, for example, make it easier for the patient to seek psychological support, telehealth and virtual services. Promote psychological awareness and reduce the stigma. Advocate for policies, registration and healthcare planning, which encouraging social inclusion, education, employment to ensure equal opportunities for IHBD patients. Further is making studies more to assess the quality of the life of the patient and what limitation they're facing. It's helping also how to advocate for policies and making it in the future and making it happen. And thank you so much for listening.
Thank you, Ms. Amani, for the amazing presentation as usual. And now I believe we'll go to the part where I don't want to be hungry by the end of the session. but I have to share that I haven't had my breakfast yet, so I need proper guidance on that. Now we'll move to the nutritional part and the exciting part also of our pillars. Ms. Lana will be taking us through nutritional management to enhance overall well-being for individuals with inherited blood disorders. Giving you a quick introduction and an overview on Ms. Lana. She is a clinical dietitian at also Sultan bin Abdulaziz Humanitarian City in Riyadh. She holds a bachelor's degree in clinical nutrition from King Saud University with first-class honors and is certified by the Saudi Commission for Health Specialties. Her work focuses on clinical nutrition care, multidisciplinary patient management, and evidence-based practice, with active involvement in professional development and community health initiatives. Please join me in welcoming Ms. Lana to the stage.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Doctor, for the introduction. Today, inshallah, we will go through the nutritional management of thalassemia, sickle cell anemia, and the hemophilia. And I'm really excited to dive in, especially after having the chance to work with the patient or inherited blood disorder through Mohja program. Inshallah, today we will dive in introduction, a nutrition care process, a nutritional complication, nutritional management, and the nutritional requirement, and practical recommendations. Despite advance in medical treatment, managing inherited blood disorder remain complex and often require a multidisciplinary approach. Nutritional status play a critical role in the overall health and well-being of individuals with inherited blood disorder. However, malnutrition is considered one of the common complications associated with these disorders, as it's closely linked to the pathophysiology of these disorders, with deficiencies in a specific micronutrient contributing to disease progression and complication, which eventually impact the patient's quality of life and overall health. Therefore, nutritional therapy is increasingly recognized as a vital component in managing inherited blood disorder to optimize their care and support long-term health outcomes. And nutritional therapy is not only limited to the basic nutritional information that can be provided on the traditional educational material or be provided by any healthcare practitioner. It's a comprehensive approach or comprehensive process that, instead, medical and nutritional therapy is a comprehensive approach that applies medical nutritional therapy according to the patient's status, based on evidence-based guideline to develop a plan that's tailored patient status. So before starting with applying a nutritional care plan, we must begin with a comprehensive assessment. We will assess the anthropometric measurement, laboratory assessment, data evaluation, and the clinical examination to assess the signs of malnutrition. Inherited blood disorder significantly impact patient nutritional status, energy level, and quality of life. Each disorder presents unique nutritional challenges, require comprehensive management strategies. In thalassemia, our two major challenges are iron overload and micronutrient deficiency. Hypermetabolism and increased nutrient turnover are the major two complications in sickle cell anemia. As I said, malnutrition and micronutrient deficiencies are part of the pathophysiology of the disease, and it's usually overlooked driver of symptoms such as clinical fatigue, such as poor appetite, poor oral intake, and GI complication. So focusing and addressing this malnutrition before clinical symptoms taking place will really improve patient quality of life and well-being. While in hemophilia, our main focus is prevention. So we focus in weight management and optimizing bone health. Okay, for the nutrition management, we need to agree on that first step of a nutritional management in all three patients of inherited disorder, in thalassemia, sickle cell anemia, and hemophilia, we need to emphasize diet. We need to emphasize well-balanced diet, high in high-quality protein, such as fish, poultry, egg and legumes, fruit and vegetables, high in antioxidant. We need to focus on the fruit and vegetables that high in antioxidant, such as citrus, berries, tomato, and green leafy vegetables. Also, daily consumption of dairy products. Sorry, I need to take a minute to catch my breath. Okay. In thalassemia, our focus on is iron management. The key here is to manage iron, not to restrict it by, to manage iron, not to restrict it by focusing on not limiting the RDAs. So we will restrict the high iron rich food, such as animal organ, red meats. Also, we need to make sure to avoid dietary supplementation that contain iron and iron fortified items, such as fortified breakfast cereal and fortified grains. Nutrition management in sickle cell anemia is to provide high calorie to compensate for hypermetabolism, assure adequate hydration to reduce crisis and sickling episodes, and reduce chronic inflammation by emphasizing high antioxidant food and supplementing as needed. We need to emphasize them on the diet first and then to supplement it on the deficiency status. Also, we will talk about this later in details. When it's come to the guidelines for fluid intake, there is no specific recommendation. The key here is to optimize hydration, depend on patients, individual case by case, to manage the dehydration. So we will, because water recommendation is vary from individual to individual, depending on their weight, height, physical activity status. So we usually taught our patients how to identify the dehydration sign and symptoms and act accordingly. Nutrition management in hemophilia: maintain aquicaloric intake to prevent overweight and obesity, prevent or treat anemia if present by emphasizing high iron-rich diet. As I said, we need to emphasize the nutrient through the diet first before supplementing. Emphasizing diets rich in calcium, vitamin D, and magnesium to support bone health. Reduce bleeding risk by maintaining overuse of anticoagulant substance, such as high doses of vitamin E, above 400 international units, high doses of fish oil, high doses of herbal supplementation, and this is considered one of the patient's favorite remedies. So we need to encourage them to not have like supplementation that contain ginger, ginkgo, and garlic. The table presents an overview of the recommended nutritional requirement. As shown in the table, energy need in patients with sickle cell are typically 20 to 50% above the RDA of the general population, which is considered double the amount of the general population. Also, the guidelines set disease-specific target of 1.2 to 1.5 a gram per kg and 1.2 to 2 gram per kg in patients with sickle cell anemia and 1 to 1.2 gram in patients with thalassemia, which is considered almost double the RDA recommendation for the general population. Which emphasize the importance of protein intake. Protein is overlooked a nutrient. Low protein intake linked to general fatigue, muscle wasting, and higher infection rate that all can be prevented with high protein intake. So we usually focus on protein intake, and we focus on assessing protein intake for our patients. For micronutrient supplementation, the table provides a comprehensive summary of micronutrient supplementation recommendation focused on providing vitamin D, folic acid, and calcium on regular basis. Iron supplementation should be avoided in sickle cell anemia and thalassemia. Additional antioxidants such as selenium, zinc, if deficient, omega-3 fatty acid may support oxidative stress management and immune function, just to make sure not exceeding 1.2 gram of ABA and DHA in patients with hemophilia to avoid a bleeding risk. The table showed a common complication absorbed by me and Ms. Fatma during with our patient in Mohja program. So we noticed that 20% of 20 patients experience difficulty to meet their nutritional need due to poor appetite, and 3 out of 5 patients with thalassemia present GI complication such as diarrhea, nausea, and severe bloating. Also, patients reported difficulties in meeting fluid requirements. So the table presented recommended solutions. I will not go through them because there are quite a lot, but you can have a picture. Also, I need to emphasize that social support is very important to address this complication. One of the patients told me that his appetite started to improve and his weight started to increase after starting having meal with his sibling. So this is very important to emphasize social and family to help them to reach their goals. In conclusion, nutritional therapy presents a promising and integrated approach of managing inherited blood disorder, offering benefit beyond traditional pharmacological treatment. There is no sign or a global dietary recommendation that fits every patient with inherited blood disorder. Individualization is the key. Nutritional supplementation can enhance the effectiveness of pharmacological treatment. However, it's essential to balance potential benefits with risk and monitor for adverse interactions. Implementing a specialized pathway ensure the best application of scientific guidelines through standardized care, improving consistency and optimizing patient outcome, which is held here in Mohja. We are working with a multidisciplinary team to help patients to have better quality of life and well-being. Thank you for listening.
Thank you so much, Ms. Lana, for the amazing presentation. And after going through the three main pillars of Muhja Initiative with our esteemed speakers from Sultan bin Abdulaziz Humanitarian City, who are a great support and one of the main pillars who made this dream turn into an actual reality with true impact in the community. Again, I would like to thank you so much for your presence with us today and your active contribution with the patient. Now we'll move to the fourth and one of the most eminent and important pillars of Muhja, which is the prevention arm, and we will know more about it when it comes to the vaccinations, the vaccination models in the inherited blood disorders, with a special focus from, I do believe, one of the eminent speakers and the both national and regional experts when it comes to vaccination modalities, Prof. Faisal Farahat, who's giving us the pleasure of his presence with us today. Prof. Faisal is the Director of Community and Public Health, Infection Prevention and Control Program at the Ministry of National Guard Health Affairs in Riyadh, Saudi Arabia. He is also a professor of occupational medicine and public health. Prof. Farahat completed his pre-doctoral training at Oregon Health and Science University in Portland, USA. He is a member of the WHO Working Group on Public Health Intelligence Frameworks, Immunization Research, and Emergency Immunization Situations. He serves as the chair of the Vaccine Utilization Committee, and his research interests focus on estimating the burden of communicable disease, particularly vaccine-preventable infections. So I really enjoyed several of his presentations and the amazing work he's done with his patients and how he really pushed the creativity and innovation when it comes to vaccinations and how to endorse it. So please join me in welcoming Prof. Faisal to the stage for his presentation.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everybody. It's a great pleasure to join this important meeting, and it's really an honor to be among this kind of eminent group who are really concerned about the patient and patient safety journey. And today we'll go through the immunization kind of models in terms of implementation wise for this specific population and group. And let me start with this kind of just symbol, I can say, but it's more very comprehensive related to describing our healthcare system in general. So it looks like we are investing much still in curative services at different levels. We do a great job for sure, but on the other aspect we are missing the other parts in relation to early detection of diseases through many screening programs, and also we are missing the other part in relation to the immunization that consider as a barrier against infectious diseases that affect the patients, and also for many lifestyle kind of intervention that can also keep the population and the community in general just far away from being close to the edge. So it looks like simply we are waiting for people to come to hospital rather than being proactive and come to their kind of places to provide what is needed to protect and to prevent diseases among those population. And this is what actually immunization do in the population, the herd immunity. Whenever the population are not immunized, we don't have a good coverage, uptake is low, so the susceptibility among different individuals is high, and the risk of acquiring infection definitely is going further. And on the other aspect, there are many patients who are very sick. Their immune compromised status may not give them the opportunity to reach an optimal response when it comes to immunization in general, and the only way is to protect everybody around them. So no other way other than this. And vaccines also are our kind of a major weapon especially when it comes to antimicrobial resistance. This is an ongoing pandemic that is really kind of a global threat. And we don't have other kind of, I can say, other kind of tools, intervention that can effectively tackle and trigger the issue of antimicrobial resistance. We fail to have new antibiotics, definitely, very, very costly, and even pharma industry researchers almost not much interested even to invest to get new antibiotics, and our pipeline for new antibiotics are really going fading out. Other kind of intervention modalities, including bacteriophage, for example, microbiomes, are really in very early stage to come to this problem. So maybe the only way currently that is available is to improve and invest in immunization in general as a very significant tool to tackle antimicrobial resistance. And very simply, vaccines prevent infection and reduce the use of antibiotics, and also reduce the unnecessary interaction with healthcare, with might be an increased risk for acquiring hospital-acquired infection among the population. And see, this is the world after the polio vaccination and immunization being there. So we almost eradicated polio disease with this good program for immunization. Only currently 2 countries with a spread of poliomyelitis, Afghanistan and Pakistan. The other parts of the world are almost or eliminated. 0 cases of polio is distributed, and this is the benefit of a good immunization program. And not only polio, but I may ask you and challenge your clinical kind of sense. So diphtheria cases, we don't see any cases anymore because of immunization. And also we don't see these tetanus cases because of immunization that been there. And pertussis, very rare kind of cases being there. And maybe the cases that we just see with pertussis are related to lacking of immunization among pregnant women. And hepatitis A is almost eliminated. Hepatitis B the same, a main cause of cancer, liver, and now we don't see cases under 40 years of age because of the introduction of the vaccine in early 1980s. And rotavirus, a main kind of a cause of death among millions of children under 1 year of age. Now we don't see such kind of a problem. And Haemophilus influenzae. This was a major cause of meningitis among young population. Now is eliminated, and we don't see much of the cases. Very rare condition to have Haemophilus influenzae cases with meningitis. And meningococcal meningitis, a real threat, encapsulated bacteria to our patients. And now again, it's very rare conditions being associated and being there. And we are very successful for sure in general throughout the journey to eradicate only one disease, which is smallpox. Since 1980s, we don't have any cases worldwide, eradicated totally. But imagine the journey took almost 200 years since the first vaccination was in 1796. Following this kind of a period, we were successful to eradicate smallpox, but yet still other diseases on the journey for eradication, including hepatitis B, including measles, including other diseases that can be eradicated by vaccination. And vaccination, the only way by our knowledge and practice, the only way to eradicate, eliminate disease is to vaccinate people. The journey continued, but there are many misinformation being encountered throughout this journey that vaccines are only for children, for kids, which is not true kind of a thing, because actually adults, older adults, adolescents require vaccination. Not only kids need the vaccine. And we didn't learn much from our kids in general, their successful program, immunization program. And what is needed is just to replicate what has been experienced in childhood immunization to the adult kind of population and adolescent throughout the journey of life. So it's not the vaccine. We do have very good vaccines, very effective, very safe vaccine being experienced, practiced throughout the years, but vaccination do the job. If we have the vaccine and just keep that vaccine in fridge, it will not benefit the community in general. And this is continue to happen, that disease is there, outbreak, imagine of COVID-19 come, vaccination uptake is increasing, the disease is eliminated, But again, confidence of population come because we don't see the disease. So I ask myself, why I vaccinate against diphtheria, Haemophilus influenzae, meningitis? I don't see such cases. So again, the outbreak happened in the population. And our journey to eradicate the disease is just delayed, and this is what happened all the time. It's not the issue always this kind of a confidence in vaccination is not only an issue for low-income countries, not an issue for middle-income countries, but also an issue for high-income countries. We see how the issue related to hesitancy in UK with the relation of pertussis to encephalitis cases, it delayed the journey. It took a long time to come back to the same kind of baseline of pertussis elimination in UK, also in Japan. United States have an issue still with measles and was there before in the 1970s with pertussis. Nigeria was the last country to declare elimination of polio because of hesitancy, that polio vaccination is related to some sort of sterility, and it continued the journey being there. But if you look at the data now, this is the current status in the United States after the measles kind of hesitancy, that you can see outbreaks in the whole kind of United States of America, and many outbreaks that not only imported but also local spread among the population. So there are lots of gaps in immunization practices has been identified throughout the years, and mainly not only for children also, but for adolescent, adult, and older adult population. And the WHO, after the COVID-19, have an initiative called a Big Catch-up, because there are 40 million children missed their kind of opportunity to be vaccinated after or during the COVID-19 pandemic. So it always comes to this kind of a gap, the no-do kind of a gap, how to cross. We have a knowledge, and our practice at the end is very minimal, limited because of many issues. It's not an issue of knowledge itself, because knowledge is not sufficient to change behavior, and we know this. So just spreading information to the population without changing their beliefs, their attitude, we communicate adequately and appropriately with our population will not change the behavior and practice of people. So always the main gap between knowledge and practice is the belief of self-efficacy, is perception of threat, which is really important among our high-risk population. And this is the initiative by the WHO called the Immunization Agenda 2030 Vision. So they're looking for a world where everyone, everywhere, at every age is fully benefit from the vaccines for their good health and well-being. The issue how to come with this, so the WHO looked for many kind of intervention, but maybe I highlight here this kind of goal from strategic priority number 4, that integration. So immunization is not yet part of our kind of a standard care for our patients. And I met many of clinicians who say, okay, I have lots to do, my patient, very busy clinic. So you ask me again to remember what vaccine, what doses, how I can prescribe. So they have lots of issues for that. But it looks like the only way to get a good job is to own the vaccination for our population and to work to integrate such kind of a clinical service with each healthcare encounter. And this will provide a catch-up vaccination for your patients who are missing some doses being there, and also to make sure that your population are fully immunized and protected. So I look for vaccination in general as a social responsibility. It's a society responsibility at the end. It's not only kind of a healthcare general practitioner or specialized physician or a nurse or a pharmacist. It's a whole society responsibility. And we learned a lot during the COVID-19. Without such kind of a work together, we will not reach to that level. Sometimes we underestimate the impact and threat of vaccine-preventable diseases, and also we underestimate the impact of such infections and outbreaks on our healthcare systems. People may die because they couldn't afford the care, because we are busy with such kind of problems that can be preventable. So in my discussion, usually with my colleagues, I try to simplify things and say, okay, immunization is not big issues, very limited vaccine that are required and are divided based on the age and the risk. So these are the only indications for immunization, either routine administration, a child 2, 4, 6 months, 1 year of age. So there are specific routine immunization for those individuals, and also adolescent population at 11, at 18, and older adult population at 50 years of age. So these are kind of a life course immunization, routine administration, regardless of the clinical condition or healthcare problem. On the other aspect, there are a population who are at risk for diseases, including sickle cell disease patients and patients with inherited blood disorders in general and other comorbidities. So there are specific recommendations for those population, and there are increased susceptibility among those people. So the risk is always, by our knowledge, is always at young age and elderly age. As we grow up in age, so our immune response is going down and the susceptibility to infection increasing. Also at very young age population, also their immune response is almost immature and require protection with immunization. Those in the middle age, for healthy individual, have a good immune response in general, but they carry the risk to transmit the infection because interacting more, they are working together, and they can carry the infection to the other kind of population. And many population in this middle age group also at risk for diseases because of their medical conditions. Sickle cell disease in general are susceptible to infections, and we know this related to the splenic dysfunction, the organ damage that might be there, the encounter of healthcare facilities in general increase the risk of exposure to diseases in general. And we know such kind of an important risk for those population, which is related to the encapsulated organism and bacteria, including the Streptococcus pneumoniae and the Haemophilus influenzae, Neisseria meningitidis, and the Salmonella species. So these are the main kind of risk for our population in general because of the asplenia or the loss of or functional asplenia among our patients. Globally, sickle cell is increasing, related to the incidence, new cases are increasing, and also the prevalence. So, alhamdulillah, with all our kind of intervention and services being introduced, we are able to give a good opportunity for people so they can live longer, and that's why the prevalence of disease also is increasing. So generally, the risk for sickle cell disease as a burden globally is increasing worldwide, and the risk for infection for sure is increasing because of their kind of disease that they acquire in general. So if just to give some highlight in important vaccines that related to specifically to our patients, starting with the pneumococcal disease that is still there. We do have a very, very good vaccines, conjugate vaccine introduced in 2000, BCV 7, then 13, later on in 2010. And now we have other kind of new conjugate vaccines being introduced, but still the risk is there because these vaccines are not covering all serotypes that been there. We have more, almost 100 serotype of pneumococcal. We know some of them that are invasive, and we are not covering all invasive types. And the serotypes are changing with time, and that's why our vaccination modality need also to be changing. Globally, almost 11% of all deaths related to lower respiratory tract infections are related to pneumococcal disease. And the new kind of an update for the pneumococcal conjugate vaccine 13, this is what is available currently, but there are additional two serotypes, 33F and 22F. This is making a BCV 15, and there are other kind of additional 5 serotypes making BCV 20. So currently we have this kind of, and for sure the selection of these serotypes are related to the clinical burden of specific serotypes being there. So now what are the current available vaccines for the pneumococcals? 13 is available, 15 also with additional 2 serotypes, 20 is available as a BCV 20 with additional 7 serotypes. And there is a new modality that including BCV 21, which is a more kind of a shift toward an adult immunization. So it's adding as a public health benefit, if we more kind of serotypes, almost additional 10 serotype to the 20. So they are not just one serotype above the 20, it's a 10 serotype, including more additional serotypes to the BCV 20. We don't have more of 23 currently polysaccharide, less immunogenic, cannot be used for children less than 2 years of age. So now this is the whole kind of change that's been there. Recommendation again based on age and risk. And the current recommendation for adult patients with pneumococcal disease, including the sickle cell disease, is to give them at least 1 dose of BCV 20 to those population. For adult people, they may also receive 21, but 1 dose is sufficient per life for those people. The other kind of burden, which is really important, meningitis, meningococcal meningitis, and always when it comes to meningitis, we think about a very kind of devastating disease that always affect our kind of people and population at different aspects. 12 serotypes are known of meningococcal meningitis, and 6 of them currently are responsible for most of the outbreaks and invasive disease. We do have vaccine for A serotype, for B, for C, for W, for Y, and also there is a vaccine that is available for the X type. So almost we do have a vaccine that covering the 6 serotypes which are responsible for most of invasive pneumococcal diseases. And we know that this kind of disease is really devastating. Without treatment, 50% case fatality rate, and with treatment it reached to 10%. The data from United States and from United Kingdom, the same kind of percentage range between almost 9 to 12% of people. It's a droplet infection, easily transmit with close contact among population, and very easy for this kind of bacteria to go through the blood, reach to the meninges, and cause a meningococcal disease in general. The issue here, which is really interesting all the time when it comes to meningitis, is the time period, because it's very short period, 24 to 48 hours just, and progress to severe death, or the person can continue with a devastating long-term disease. If we compare the case fatality rate of meningitis or invasive meningococcal disease, it comes after Ebola, it comes after avian flu that reached to almost 60% death rate, and then invasive pneumococcal disease. It's really kind of a disease that affects those people, those who survive of death, so they may come 20% at least with a long-term impacts, cognitive impacts, disabilities, amputation might happen, a hearing loss, seizure that can affect those population, and lots of other long-term impacts. And our population is at risk for this kind of disease, and we know this, how meningococcal is the main risk for patients with inherited blood disorders and sickle cell disease population. This slide simply simplify who at risk for invasive pneumococcal disease, and we can see all kind of social, environmental, individual factors, and also people and our colleagues, microbiologists, who are working in direct contact with the Neisseria meningitis require a comprehensive coverage, not only with the ACWY vaccine, but also they should vaccinate against meningitis B vaccine, so covering the whole kind of 5 important invasive meningococcal disease among those population. Again, people sometimes perceive they are healthy, and especially the young adult population, but they are carriers. And imagine that the carrier stage among population who are adolescent, young adult in crowding condition reach to 50%. So the risk is always there all the time, and the risk of transmission to the population is always very high. These are the available licensed vaccines covering the ACWY and meningitis B available in Saudi Arabia with different kind of manufacturing and also licensed year and approved age for those population. So what's there? Surveillance worldwide. We can see a different kind of a spread. Is a mosaic kind of a picture that all serotypes are there worldwide. But maybe probably meningitis B is more in the western and north part of the hemisphere, affecting many population. And the other aspect that we don't have data in our region. So maybe in Saudi Arabia, for example, the latest study was in 2012, more kind of a very limited data, and we don't have data to update our knowledge related to the circulating specific serotypes of meningitis. And this is an example from Europe, where you can see how the spreading of meningitis B in different countries in Europe. and maybe kind of an intervention, immediate, proactive intervention from the United Kingdom with introduction of different vaccine and changing their kind of vaccine recommendation based on the circulating serotypes. So they introduced MenC in 1999 after an outbreak that happened in the UK. And in 2015, meningitis B, since that time, is included in the NIB, the National Immunization Program, as a routine administration for children at 2 months, 4 months, and a booster dose at 12 months of age. And also introduced the ACWI for adolescent population to give them an additional protection for those people. So what about our region? Hajj always an issue and a concern when it comes to Saudi Arabia, and 13 countries out of almost the 185 countries represent 70% of pilgrims who came for Hajj. And when we look for the available data in these countries, we can find an average of almost 65% that of the serotype that been identified in these countries are meningitis B. Which is not currently a routine work or administration in many of the countries in this region, although the data are almost based on healthcare or hospital-based data in general, but it gives us an impression how the spreading of meningitis B in our region is really high and concerning. If I take you back in history, the first outbreak in meningitis happened in Mecca was in 1987. That was related to pilgrims who came from Southeast Asia to Mecca, and after the outbreak happened in 1987, there was an outbreak of 30,000 population with meningitis A in Africa the year after. So how this kind of interaction happened, and the risk always in Hajj, especially for meningitis. Several outbreaks happened during Hajj throughout the years. Maybe the latest was in 2000 and 2001 with a new kind of serotype, which is meningitis W, being identified for the first time almost in this region, and come with a case fatality of 30% of those people affected during this outbreak died. Since that time, with introduction of very comprehensive program requiring and mandating ACWI vaccination for everybody coming for Hajj and Umrah to be vaccinated, we see a dramatic drop in cases in Saudi Arabia. However, still cases reported throughout the years, and our surveillance is lacking and limited. We don't know exactly what specific serotypes are currently spreading in our population. So our kind of intervention with these kind of disease are really emphasizing how prevention can work and can support our population in general. And now the current recommendation in Saudi Arabia for people who come or going for Hajj, whether local pilgrims or international pilgrims, to receive ACWI vaccine, and also routine administration for children at 9 months and 12 months being introduced, ACWI, and also another booster dose at 18 years. This is routine administration for ACWI, which is university age. But for meningitis B vaccination, the current recommendation is for high-risk population, including, and the top of the list are the sickle cell patients and patients with asplenia or splenectomy in general. The WHO launched this initiative to eliminate meningitis. This is a defeating meningitis initiative by 2030. And again, to eliminate meningitis, the only way is to vaccinate our population in general, including the high-risk population with meningitis, pneumococcal, and Haemophilus influenzae vaccines. So this is the message that I wanted to emphasize, that Hajj is always an opportunity to update our patients' kind of vaccination, and should be not only for meningitis vaccination, but for the other required routine vaccine to be administered. I will just go in short for other important vaccines for our patients, including annual influenza vaccination that is required for all population to be given from 6 months of age and above during the season from October 1st until end of March. Each year, everybody must be vaccinated against influenza, and influenza is kind of a dual phase. So sometimes just a common cold issues, but every 10 years there is an outbreak, and sometimes epidemics or pandemics might happen with a new virus being there, and death is huge. You can imagine that there is almost a 500,000 people die each year because of influenza infection among our population, and the virus keeps changing all the time. So when it comes to children, so it's been identified that children are some kind of a host, so they interact easily, they carry the infection and transmit to the community. That's why vaccinating children with influenza is really crucial, and we are missing this. We consider that influenza is for elder adult population, but not for children, and that's why we don't have a good vaccination program among children in general against influenza. Human papilloma virus is a really important vaccine that's been there. It's the second cancer preventable vaccine being identified and being recommended for adolescent population, and has been identified that human papilloma virus is the main cause for cervical cancer and other kind of oropharyngeal and anal cancers among male and female. And the vaccine that are available, including the quadrivalent 4 types, or the 9-valent vaccine that cover many kind of types that are responsible for cancer occurrence. So if I come to maybe my last slide here, to focus on our goal is to vaccinate people, vaccine uptake. But when it comes to vaccine uptake, there are many kind of issues that need to be discussed at the end. And maybe in our country, the most important to look for is access to vaccine. So just imagine your patient, where he can find a clinic who can vaccinate this patient. Vaccines are available in primary care centers everywhere, and it's available for free for everybody who's living in Saudi Arabia. So anybody can go to any primary care center to receive their kind of vaccination. But what we are lacking a good communication with our patients. So we don't offer the vaccine for our patients, and we don't consider vaccination as an integral and important standard of care for everybody who is there. So in terms of affordability, it's affordable in Saudi Arabia, alhamdulillah, everywhere, but we need to work in 2 important things. First, access, and second is the awareness. And awareness not only the healthcare providers, because many of the healthcare providers are still hesitant against vaccination, but also awareness of the community themselves, so they can interact patients, communities, and the healthcare provider in order to reach to the vaccine uptake in general. And at the end, I don't assume that we do have a hesitancy in our country. It's just an access and awareness issues in our population. And I think this is the most important priority to focus and to work, is to communicate appropriately. So the way how healthcare providers discuss and communicate the right message for their patients, especially with a world now with lots of misinformation and disinformation are really kind of affecting the whole kind of scope for prevention and care for the population. So with this kind of a dilemma of misinformation that is spreading through the social media, we need to change our way of discussion and communicating with our patients, especially for important interventions that are immunization and other preventive measures. So with this, I would like to thank you all, and thanks Dr. Hatoun, Dr. Ahmed for the invitation. Thank you so much.
Thank you so much, Prof. Faisal. I would like to invite you and our esteemed speakers, in addition to Ms. Fatima, to join us in our panel discussion. Please, we're going to have a panel discussion for the upcoming 10 minutes, so if you have any questions regarding the presentations on the 4 pillars of Muhja, again, a quick reminder, we covered the physical part, we covered the psychological, nutritional part, and we ended with the prevention and vaccination with Prof. Faisal. So we'll be more than happy to take your questions and then accordingly move forward with our agenda. question from Prof. Lewis. Please, can I have a mic, please?
These were brilliant presentations, and I especially appreciate all the pictures. I was taking as many pictures as I could, and I hope you don't mind that I copy some. I was particularly interested in whether the whole package that has been presented will be published for other people to learn. When I refer, for example, for physical therapy in Chicago, I send a sickle cell patient, I say, please help this sickle cell patient. They need preventive, they need long-term intervention. I get back 6 weeks, we're done. They can walk, they're done with their objectives. So they do not have the same kind of tailored approach that you have already created for the blood disorder patients. Can you say how much of this Moja creation can be presented for other colleagues very soon?
I guess I will be the one taking this question on behalf of the team, and also Dr. Atun can comment on that if she wants. Currently, we have the Moja portal. It's live on a national scale so far. We're building it bit by bit. After we finish our first pilot of our 20 patients, we're getting several learnings from them. We're adding them to the portal, and I believe by the end of Q1, quarter one this year, inshallah, when we do the graduation for our first wave, we will be ready to go even global. We will be happy to share the link for Moja portal so it can be utilized by all of the physicians and all of the societies across the globe. We have, of course, our eminent partners that are supporting us with references, either WFH or TIF when it comes to these diseases, and of course our esteemed team who are covering the pillars that we were talking about. So there will be information from patients, information from the certified coaches who are leading this journey, and it will be bilingual to ensure that it's either, if it's in Arabic, for the convenience of our patients, we will make sure that it's translated and it's in a way that can be easily utilized by both global and national patients.
That'd be great. Thank you very much.
Thank you, Prof, for the question. Okay, so Prof Hatun has a question, and Doctor has a question.
I have a comment and a question. Just to answer Louis' question, we are actually writing up the consensus statement for Moja for well-being. So this, inshallah, will be released and published by the end of the year. And still, it's a statement from Saudi Arabia, so that's we will share our unique experience with the world, inshallah. I want to really take the opportunity to thank all people sitting there on the stage. Sultan bin Abdulaziz Humanitarian City has been from day one super dedicated, and you cannot believe the quality of dedication that they're giving to us. Professor Farahat has been working with us on this, and he's quite enthusiastic. And then when we built Moja at the beginning, probably there was no focus on the prevention part a lot, but with him and working together, I think we believe that there is a very huge role about prevention to play in the well-being. My question to Dr. Farahat, Moja is a national program. As a hematologist treating inherited blood disorder patients, there is always a gap when it comes to vaccination. If the patient doesn't come for their regular follow-up with hematology, we don't necessarily prescribe. If I'm alerted enough as a hematologist, I do prescribe, and then I don't know where my patient will go. Is it primary care that will send them there, or the daycare unit for hematology will give the vaccine, and then our nurses refuse? We always have this struggle. I've worked in different institutions with different structuring system, where some of them will ask the patient to go to the pharmacy, pick up the vaccination, come back to receive the vaccination. And it depends on the entry as well in the system, so I find that the entry is very poor. So there is always a gap, and I'm glad that you presented the vaccine uptake. But what are your guidance to develop a tight national program. The Ministry of Health did a great job in the platform of Sihhati. So Sihhati on its own has the luxury for patients to log into their application and go to the vaccination clinic. So there is a button for vaccination clinic where they could book their vaccination. So there is patient awareness, public awareness, vigilance of the medical team, but even sometimes vigilance of the medical team does not ease the process for patients to receive really their timely vaccination. So I would like to hear your advice on this, to have it as a tight national program.
Thank you so much, Dr. Hatoun, for all your efforts. Yani. I really admire what you do and really supports all the activities by Mohja and our team. In terms of your question, it's really kind of a pain all the time when you have a patient and just you don't know where to produce or to provide the needed vaccines for them, and I think the same issue with many kind of other high-risk populations. I believe on first the system, how can the healthcare system in general can help and support, because this is maybe an easy job we can do and enhance. And for sure in Saudi Arabia, what has been done with the National Vaccination Registry, it's really kind of a tremendous effort that's really important for our patients, because you know, before we have a card, vaccine card for the children, but what about other kind of age groups? We don't have their documentation for vaccination at least. But now anybody can just go to his Sihhati application and can see the history, the patient, a healthcare provider. So this is an example how the system can improve such kind of work that's been there. Our kind of electronic medical records are everywhere available. So an easy kind of a package for those specific patients can be also implemented, so it does not take much of the thinking or a search for a healthcare provider to just click it for it. A reminder systems are easily being implemented in different places. So many other issues can support, including artificial intelligence issues. So I would like to focus first on the system base. So we need to improve, enhance our systems toward immunization. And the second part, which is really integral, the individual themselves. We spend a lot with our individual, but you know, we face some kind of an issues. They are not, maybe some feel they are not competent enough. They forget about, they are not trained. We don't include vaccination, immunization in training programs for College of Medicine, for College of Nursing, for College of Pharmacists. It's not there. So they are not kind of feeling not very competent on that. So having a guideline by you and the colleagues in relation to specifically those patients may help our patients. Having such kind of interactions, meeting such things may increase their competency at the end and can support their kind of a knowledge. And at least what we need from individual to perceive a threat, that those patients are really at risk. You spend a lot of medication intervention for them, but they may have a long hospital stay, for example, may be at risk for death because of infection that can be prevented by a vaccine. So focusing on both system and improving the competency of our individual. And part of the competency for our patients, for our healthcare provider is the communication, as I mentioned, but the communication, the way, don't share the issue with your patient as you are reluctant, as an optional thing. Just have a presumptive. So I will vaccinate you by the end of the clinic because you are due, or this is a season, for example. So having a presumptive message is always encouraged for our patients and for our healthcare providers.
So we have one more question.
Assalamu alaikum. Thank you, Dr. Faisal, for your informative talk. My question about human papilloma virus. There is a program now for a female vaccination, pre-marital stage. What about male? You said vaccinate male. What is about male?
For human papilloma virus, in Saudi Arabia, the current recommendation is girls only. And the age for it as early as 9 age, so until 45 years of age. So these are individual age can be given routinely between 9 and 26, and from 26 years of age till 45 is based on the risk a decision, kind of a clinical decision. But current recommendation in Saudi Arabia only girls. Worldwide, many countries, yani almost, I can say 40% of worldwide countries having what's called a gender neutral. So they provide the vaccine to both girls and boys. It's licensed for both of them, but recommendation is only girls.
Okay, so with that, we'll end our panel discussion, and I'll invite Dr. Hatoun to the stage. If we can have, please, we want to give the trophies to our speakers, our esteemed speakers and panel. Miss Amani Salami, please. Miss Arij. Miss Lana. Miss Fatma, who's been with us from the first day. May I also invite Dr. Arwa to the stage, please? Arwa, yeah, yes.
If you allow me, I would like to take this opportunity really to thank Dr. Hatoun and Dr. Ahmed and Umawich and Smart Health team for this opportunity and for their true and valuable dedication and hard work towards patients with blood disorders. Really, your hard work is showing out, is really showing in a great way, especially in your focus and maintaining the good quality of life for our patients. And we're really, as a Muhja team and Prince Sultan bin Abd Aziz Humanitarian City, are really happy and glad to be part of that journey. Thank you so much for your hard dedication.
Okay, I guess because of the time crash, we'll move to the two more sessions before going to lunch. I have my bios for the moderator on my phone, and I'm not gonna go down to bring it because those two moderators are honestly, everyone is special here to me, but those two moderators are very, very special to me. You will see their probably bios. Our first moderator is Dr. Samiha Al-Awami. Samiha is OB-GYN with fetal-maternal medicine. She is in Khubar, National Guard Hospital, and she has a very wide experience with dealing with the fetal-maternal part of inherited blood disorders, especially sickle cell and thalassemia. But Samiha is my friend and sister since we were first year of college in medicine.
It happened that Samiha lived in Jeddah with a nice group of girls that were 10 steps from my dad's house where we used to live. And my dad doesn't allow me to go to any of the friends, except every day in the morning I do the 10 steps, going to their house, going to the college together, studying together, having our exams for 6 years of my life. When I came back from Canada after 20 years, I came to Khubar, and the first call I got was from Samiha. So the second moderator of the second session is really a person close to my heart. Dr. Fawaz Al-Qasim is a pediatric hematologist, but Dr. Fawaz, since I joined the ministry with this work in 2019, has been the first one to step and come and say, do you need help? The statement is, do you need help? He has been the champion of our hematology clinic department at the Saudi Virtual Hospital, the Saha Virtual Hospital, and he had been really the dynamo and the turbo for such an initiative at the for the virtual care. So Dr. Samiha, I invite you to for the session. You guys were looking at me and you should have waved. طيب, I do apologize. So that was supposed to be the normal agenda. However, Dimitris from the Thalassemia International Federation has to fly earlier. So we did a switch and I forgot because I was reading the agenda earlier. So the session actually will be for the Thalassemia International Federation, our partners, collaborators, friends, and where we signed the MOU, and the MOU we signed yesterday is not the beginning. One of the pillars of the MOU is publishing the consensus. So it's a pleasure to say that we've published the consensus the same day that we signed the MOU. So the floor is yours, and then we'll go to my friend Dr. Fawaz Al-Qasim after, and then lunch.
So good morning, everybody. Thank you for the kind invitation to this important conference that reflects the high level of healthcare to our patients with hemoglobinopathies in the kingdom. And sorry for this last-minute change in the flow of the program. I'm here to represent the Thalassemia International Federation and provide the perspective of the Thalassemia International Federation for the management of patients with hemoglobinopathies, thalassemia in particular. May I have my slides, please? Okay, thank you. My disclosures. Now I will start by touching upon the burden of the disease of thalassemia. And as you know, this is the hemoglobinopathies are the most common monogenic disorders in human, with being a significant health problem in 70% of the WHO countries. So it concerns the whole world. The general carrier rate is around 7% of any hemoglobinopathy disorder, and we estimate, it's a very rough estimate, that there are more than 300,000 people born annually. Most of them concern sickle cell disease, and the rest being thalassemia. Focusing on thalassemia, we know now that we have more than 500,000 patients suffering the disease, with more than 55,000 patients born annually, and this translates into a huge socioeconomic burden. This comes from the UK, and you can see that the cost of a patient till the age of 50 is almost £500,000, and this has been increasing over the years. So this is followed by a huge socioeconomic burden, and we have experienced a lot of population migrations, particularly from the Middle East and North Africa to Europe and other countries. So this is changing the epidemiology of the disease. Now, epidemiology does not equals the burden of the disease, because if we want to have a definition of what is disease burden, it is the impact of a health condition measured by different measures and affecting different populations or different metrics of interest or parties of interest. So we have different measures for burden, like very hard endpoints like mortality and morbidity, but even softer ones like quality of life, financial cost, social impact, and so on. And we have different parties affected by the disease that we need to consider, including patients or the families of patients or the carers of patients or the society at large or the healthcare system or the budget and so on. So the burden depends of what we measure and to whom we are considering. Now, to understand the burden of thalassemia, it is not a very easy thing, because thalassemia is a lifelong, genetic lifelong condition, requiring lifelong expensive therapies and follow-up, multi-morbidity, and need for multidisciplinary care. So the burden has many, many different aspects that need to be considered. And there is also many parameters that we need to take under consideration to measure the disease burden, like epidemiological parameters, clinical parameters, financial ones, and psychosocial ones, and just a few measures of the disease burden that we may consider. The number of patients shows us actually the real treatment needs. Now, the age distribution of the population is also very important, reflecting what we do with prevention, what we do with the outcomes of our treatment, what is the quality of care. Then we have the complications rates against a measure of the quality of care. The needs in treatment modalities like transfusion, chelation, monitoring, multidisciplinary care, the needs in social support, it is relevant with treatment coverage, allowances, and so on, and also the cost that may be direct financial cost, indirect financial cost like productivity loss and so on, but also other types of cost, not necessarily financial, like the suffering of the patients, the quality of life, the social burdens, and so on. So there are different aspects that we should consider in order to have a better idea of what is the real burden of the disease. And of course, a lot of evidence can be found in this annual edition of the Thalassemia International Federation on the Global Thalassemia Review that is updated every year. Now, how to address the disease burden in terms of thalassemia? And this is a nice Arabic, I think, gate with two pillars. The one pillar is treatment, and the other one is prevention. And I will start with treatment. We know there have been dramatic evolution in the therapies for thalassemia patients over the past decades, and this is accelerated over the very recent years, and this has translated into a dramatic improvement in survival rates. And now in populations where there's access to proper care, the population tends to be a normal lifespan. The survival tends to reach the normal lifespan of affected populations. And this, of course, has to do with the treatment of the disease, and treatment has to do with addressing the actual pathophysiology of the disease. So we need transfusions to address anemia, chelation to address iron overload, and multidisciplinary care to address the multi-system involvement of the disease. And also, this has to be a multidisciplinary, patient-centered approach to work better and more efficiently. At the same time, we have additional novel therapies that address the actual disease itself, like gene therapy and novel drugs, and not the consequences of the disease, like anemia or iron overload. And we have a lot of innovative treatments nowadays. Why do we need innovative treatments? Because we want to cure the disease instead of treat. That would be ideal. Reduce further the morbidity and mortality of the disease, address specific unmet needs not addressed by traditional treatments, and also provide options that may work better under certain conditions. And as you know, we have gene therapies with gene replacement, gene addition with the new technologies, and new drugs like luspatercept and mitapivat. And this is actually the first country where mitapivat was licensed for thalassemia patients. But what is the actual access to those therapies? This is very, very limited if we consider the whole world. More than 80% of the patients across the world face immense challenges in addressing, in accessing timely and appropriate health care. And this is the actual situation nowadays across the world. Some numbers: more than 60% of patients with severe hemoglobin disorders have no access to quality care. Only 12% of transfusion-dependent patients actually receive regular, proper transfusions. Less than 40% of those regularly transfused have access to proper chelation therapy, and of course this has to be related with the fact that the vast majority of patients live actually in low resource countries. This is the situation that we need to deal with nowadays, so access is the major problem. Now, moving to prevention. Prevention is very, very effective. This is evidence from Cyprus. The prevention program started in early 70s, and you can see an immediate drop in the number of affected births. And this also translates into a cost reduction. Of course, there is cost also for prevention, but this is very cost effective, as the cost for prevention of 1 year equals to the treatment cost for 2 months. And I think this is very, very important. And also what we observe with good prevention and effective treatment is an aging of a population. This is a great success to have populations that are now age. So we have new problems, of course, to face in the aging population, but this is a success of prevention and treatment. Now, for a good prevention program, we need public awareness, we need population screening programs, genetic counseling, prenatal diagnosis for couples at risk, pre-implantation diagnosis, and also ethical principles that need to be taken under consideration. And this is another list of ethical principles like the voluntary participation, autonomy, right to full information, confidentiality, informed consent. So if we want to have good prevention and good treatment, we need national strategies to support both strategies. And national strategies means that we need a national plan, a national coordination at the national level, international support with different, from different associations and societies, WHO or Thalassemia International Federation, engagement of all stakeholders, education and awareness programs with multiple targets, physicians, patients, families, the society at large, and so on, proper budget allocation, continuous monitoring and evaluation. This is very important, and we need specific quality indicators like age distribution, pre-transfusion hemoglobin levels, serum ferritin levels, cardiac to-stack, liver iron, social determinants of health, and so on, that we need to monitor throughout time to see what is the quality of our program. And of course, we need data generation with proper national registries. what kind of data we need in the registry. We need a lot of different types of data, like you can see here, data on disease morbidity, prevalence and complications rate, demographic data, data on the access to therapies and to monitoring a proper multidisciplinary follow-up, and also data on the outcomes of our interventions. And we could gather all this data, we can use them, leverage them to see what is going on with the actual disease burden, to benchmark our approaches, to detect unmet needs that need to be targeted, and to detect any inequalities or disparities in healthcare provision. And this type of evidence will be useful to a big spectrum of stakeholders like government and care policymakers, regulatory bodies, clinicians, researchers, patient organizations, and the pharma industry. So generating proper evidence is very, very important for all stakeholders implicated. And WHO mandates actually the development of an implementation of national programs for the management of thalassemia that need to be tailored to specific socioeconomic and cultural contexts in the different countries. In Saudi Arabia, we know that there is a high incidence and prevalence of the disease, particularly in the south and eastern part of the countries, both of thalassemia and sickle cell disease. And in TIF, we're very delighted to see that there are a lot of innovative initiatives now going on. There is this Saudi Health Sector Transformation Program, the National Health Command Center, the SIHA Virtual Hospital. I was there visiting it in December. I was really impressed with the facilities and the infrastructures, and also the Moja project led by Dr. Khalifa, presented earlier today, concerning sickle cell disease, thalassemia, hemophilia, and so on. And particularly important initiatives that need to be there to establish a good national programs. And this program here in the Kingdom has everything that needs to be present, like a national registry, we discussed about it, screening programs, vaccination programs, multidisciplinary care, access to curative therapies, access to innovative therapies, and also the Saudi consensus statement that we talked about it yesterday and earlier today. So everything is there, and these things are important to promote equitable access to high quality and innovative care for all patients. And we are very glad to see that actually this is happening right now and can be used as a blueprint for other countries. And we were happy at TIF, extremely proud and delighted to be part of these initiatives with the memorandum that we signed yesterday, and also the new document, this consensus document that will be released over the next weeks. And we hope at TIF that there will be many other projects in the near future, and we're really proud and honored to be part of these initiatives. A few words for the role of TIF. As you know, the Thalassemia International Federation was founded in 1986. It is a patient-driven organization, umbrella organization, with members of patient organizations from many countries, more than nearly 70 countries, with more than 250 member organizations, and in official collaboration with WHO, the United Nations, the European Union, and the Council of Europe. And the main pillars of TIF work, as you know, is education, research, awareness raising, advocacy, and networking. With TIF, we provide different tools for the better management of patients, like defining the best practices with our guidelines that are written by experts from all over the world for the management of patients, with transfusion-dependent thalassemia, non-transfusion-dependent thalassemia, alpha thalassemia. There are new guidelines that are going to be released in the near future, a new guide on the emergency management of hemoglobinopathies, and another update of the transfusion-dependent thalassemia guidelines that will be released over the next months. We have developed other tools like this tool that estimates the cost of the disease at the national levels, and this is a nice tool provided by TIF. It can be accessed through the TIF website, and you can actually calculate the different types of cost of the disease, direct cost, indirect costs, and so on. And we can compare this weight, the cost between countries, like in this example. Another tool is this one that estimates the actual thalassemia-related disability with different components that can be used to actually calculate, to estimate the disability of the disease. And of course, creating regional networks is also very important. With the initiative of TIF, there are networks like the TATAF network, the Arab Thalassemia Association Forum, a Nordic network, Southeast Asia, Pan American, and so on. There are also an Indian subcontinent network that has recently been formed, and this is actually very important. Last but not least, of course, promoting education and awareness through different modalities like conferences, webinars, publications, online courses for physicians, patients, and carers. The networking apps like the Thalia app, and of course Tiflix, which is like Netflix, but without having to pay anything for that. And everything is, of course, free of charge. So with this, I thank you for your attention. I thank you very much also for the opportunity to participate in this conference. Thank you.
Assalamu alaikum. I'm truly honored to be with you today, representing TIF. My presentation, I was asked to be on the transformative value of gene-based therapies for patients living with hemoglobinopathies. So back to the science again. What am I doing wrong? Okay. So no much need for this audience to dive into the pathophysiology of hemoglobinopathies. I would like only to underscore that thalassemia is caused by more than 300 mutations, and thalassemia is a matter of quantity, caused by the excess production of normal alpha chains over the absent or decreased beta chains, which result in an unstable hemoglobin tetramer, and is responsible for the ineffective erythropoiesis, anemia, organ damage, and the known effects of beta thalassemia. In contrast, sickle cell disease is a matter of quality. Here, one single mutation causes the generation of an abnormal hemoglobin S, which under hypoxic conditions polymerizes and causes the red blood cell sickling, and the known symptoms and signs of sickle cell disease, vaso-occlusive crisis, inflammation, etc. In the recent years, we have witnessed a paradigm shift in the treatment, in the landscape of the treatment for hemoglobinopathies. Until recently, the standard of care included for thalassemia, transfusions, and iron chelation, and for sickle cell disease, hydroxyurea. And also allogeneic transplantation, which, although a curative treatment, is associated with several limitations, including the limited availability of well-matched donors, the narrow window application to the youngest patients, and the need for long-term immunosuppression to avoid the immunological risks of allogeneic transplantation. In the recent years, genetic treatments have come to the forefront. So we have gene therapy with the addition of globin, of a normal copy of the globin gene to the patient hematopoietic stem cells, and also gene therapy by gene editing, where the induction of fetal hemoglobin is implemented. So these genetic treatments can offer a curative potential to those who lack acceptable donor or who are at high risk to undergo allogeneic transplantation. So there are two types, approved types of performing gene therapy by gene addition or gene therapy by gene editing. So in the first type of gene therapy, a normal copy of a beta or gamma globin gene is introduced through a lentiviral vector into the hematopoietic stem cells and can produce the normal protein. So this approach is a universal approach and mutation independent. So you understand that irrespective of the underlying mutation, if you introduce the whole gene into the cells, you can treat, cure both thalassemia or sickle cell disease. On the other hand, gene editing is a more precise approach where a specific site on the genome is targeted through the CRISPR-Cas9 platform. So this approach gives us the opportunity to either inactivate a gene, which can have a disease-modifying effect, or if a donor template is also driven to the specific site to have the mutation corrected in situ. So this approach is site and mutation specific. However, it can have also universal effects if we induce through this approach the hemoglobin F. So both approaches can have a universal effect. So the next generation of gene editing offers safer approaches without causing double strand breaks in the DNA and having less off-target effects. And these approaches are base editing, prime editing, and epigenome editing. Currently on preclinical research, but there are no approved gene editing approaches yet with these platforms. So the patient journey to cure starts with the mobilization and the collection of stem cells for the patient, which is quite challenging for this for patients with hemoglobinopathies. It involves a centralized manufacturing process, and then the product, after having going all the safety and quality tests, are sent back to the patient center. The patient receives busulfan myeloablative conditioning, and after the product is infused, the gene-corrected cells engraft and produce functional blood cells. So usually the clinical trials anticipated a 2-year follow-up and then an optional long-term follow-up for 17 years. So as I said, the first step for starting gene therapy is to collect safely and effectively high numbers of stem cells for the patients. In thalassemia, we were the first to show several years before gene therapy clinical trials start that the combination of G-CSF and plerixafor is the most suitable strategy to collect safely and effectively high numbers of hematopoietic stem cells in patients with thalassemia. Mobilization in sickle cell disease proved even more challenging, as in these patients, G-CSF has been associated with severe vaso-occlusive crisis and sometimes, and in one case, a fatal event. So the first trials started collecting stem cells from these patients by bone marrow harvest. However, the yield was very poor, and the patients were regrafted with very low hematopoietic stem cells, so the effect was suboptimal and not curative. So then in the case of patients with sickle cell disease, plerixafor was, as a single agent, was shown that it was that could enable sufficient numbers of stem cells be collected from these patients, with some precautions, however, before and after mobilization and leukapheresis. I was very interested to hear yesterday that in the real-world practice here in Saudi Arabia, the Arab colleagues have attempted to mobilize sickle cell patients with a combination of G-CSF plus plerixafor, being very cautious in preparing the patient before they received G-CSF, and actually I'm very looking forward to see a larger number of patients being mobilized with a combination, and if this will be indeed seen to be effective, safe and effective, it will be a game changer in the case of sickle cell disease patients. So the first approach, gene therapy by gene addition, I will first present this data. So I will present the data from the phase 3 trial with the Zideglo product, in which in the severe genotypes, beta 0 or IVS 110 genotypes. In this trial, we also participated treating 2 patients with transfusion-dependent beta thalassemia. In this trial, all ages were involved, kids, adolescents, and adults. The patients had, as I told, the severe genotypes only, with a heavy history of previous transfusions. The median collected cells were almost 30 millions. The median cell infused were 11 millions per kilogram. So this underscores actually the loss that there is during manufacturing and the need for collecting high numbers of stem cells in these patients. So the time to neutrophil engraftment was 26 days, 50 days for platelets, quite prolonged according to what is typically expected from an autologous transplantation, and the total hospitalization time for these patients, 42 days. You may appreciate that very early after their gene therapy, patients became transfusion independent, and they maintained independence for up to 5 years here. 90% of them, and with hemoglobin, median hemoglobin level of 11 grams. Very recently, we published the long-term efficacy and safety results of the patients undergoing gene therapy with Zideglo, and in this picture, you can appreciate that patients that reached transfusion independence maintained this status up to 8 years across all genotypes and ages. Their hemoglobin level for patients in the phase 3 trial was around 11, much lower for the phase 1-2 patients, and this is because this was before the refinement, the final refinement of the manufacturing process. So now the commercial product usually retains these levels of hemoglobin. And of course, these levels of hemoglobin translated to significant improvements in the iron burden in these patients, and the vast majority of them stopped iron chelation after having restarted it post-gene therapy. So regarding the safety profile, it is consistent with what is expected for myeloablative conditioning, so I will not go through the acute toxicity of busulfan, but I want to underscore that all patients are alive at last follow-up over a very extended follow-up post-gene therapy. There have been no malignancies, insertional logogenesis, clonal dominance, or graft failure. And the same product by gene addition was also used for the treatment of sickle cell disease. So, as I told, it is a universal procedure. I will not go through details here, just to show you that with this product also, patients with sickle cell disease have been severe vaso-occlusive crisis-free after gene therapy. and that the other type of gene therapy, which is approved also in the Western world and in your country, is the gene editing approach, where the rationale is to reactivate fetal hemoglobin. I won't go through this details, as we have heard them yesterday by the Arab colleagues. This is the Vertex results. To highlight that both products, the gene addition product and the gene editing product, have received approval. Both are approved in the US. In Europe is only approved the Vertex product. However, the real world practice has not yet been initiated in European countries except the Great Britain and very recently, I think, in France. I would like to make a comment on this exorbitant cost of these new therapies, the advanced medicinal therapies, that this cost range from several hundred thousands to millions, as you may see. So this put intensive pressure to the health system payers. And also the reimbursement traditional model struggles to align with this new financial reality, and has adopted even some outcome-based models of reimbursement. So this new era with personalized treatments and living drugs with these highly sophisticated therapies and the exorbitant cost has drastically challenged the pillars of disease treatment, the availability, accessibility, and affordability, as the extreme costs deepen inequality between patients, making the access to curative treatments impossible or critically delayed. And here I would like to congratulate your country for providing equitable access to these treatments to patients. Okay, I would like just to comment that the future for gene therapy for hemoglobinopathies will be the in vivo gene therapy. I don't have time to go through, but this is something that we explore the last years in collaboration with University of Washington. So we think that by this approach, no leukapheresis will be needed, no myeloablation, no ex vivo processing, and no transplantation. So we have shown this in several publications. And here I would like to stop with a smiling face of two cured patients, the two Greek patients that have been cured with the one gene therapy approach, and to thank you for your attendance. Thank you.
Assalamu alaikum. Now, without any further ado, we'll move to the next speaker. But before that, I would like to thank Dr. Hatoun for the invitation, and most importantly, for the excellent job that she did to improve the care for inherited blood disorder patients in our country. Thank you, Dr. Hatoun. Our next speaker is Dr. Farah Shah. Dr. Shah is a consultant hematologist at Borjel Medical City in Abu Dhabi. She is also the head of Thalassemia and Hemophilia Center in the same institution. She's an associated professor in Khalifa University in UAE, and her special interest is hemoglobinopathy, with many publications and presentation internationally. Today, she will talk to us about innovation and transition of care. Dr. Shah.
Assalamu alaikum everyone, and I want to just say thank you very much to Hatun and the organizing committee for inviting me to speak on transition. There is no innovation in transition. I think the innovation in transition is our own mindset about how we recognize transition in patients. So this is my disclosures. And although the slides focus on thalassemia because it's got a more complex transition process, this is equally applicable across the board for patients with sickle cell disease. So we have historically thought about transition as being a transition from pediatric to adult services, but actually transition reflects changes throughout a patient's lifetime, and that includes transition for parents as well as transition for the people who are affected by the underlying disease. So in my opinion, transition points are these 4 primary transition points, but I forgot to mention that the very first and most important transition point is when the parents have a child affected by a hemoglobinopathy, because they have to transition from a normal life to a life where they're going to have to deal with a child with chronic long-term health issues. So the first transition point in our patient population is transition point 1, and this needs to be done incredibly well, because if you make mistakes at transition point 1, you will pay the price, as will the patient and the families, as they move through the other transition points. So this is really important that we focus on the child and the parents, and I cannot stress how important it is that both are focused on. So as soon as a child starts to develop understanding, ensuring that they are, with child-appropriate language, understanding what their disease is, and this requires multi-level reinforcement from parents, nurses, doctors, and psychologists. When a child understands that they are not the same as other people, they will actually be able to be in a better position to manage and take control of what is going on around them. Developing autonomy is really important in children. If you do not develop autonomy, they will be unable to make decisions independently about their own health outcomes. And this is absolutely critical, that we start to encourage autonomy in our children from an early age and empower them to support them in decision making. And this can include simple things like how to manage side effects with their iron chelation therapy, how to manage side effects with their hydroxyurea therapy. And developing self-efficacy is really important in children and young adults, and it's around managing their routine, remembering to take the medication, confidence in discussing similarities and differences between themselves and their healthy siblings and their healthy friends and cousins. Parental education is absolutely essential. If you don't get the parental education and training correct, that child will not be an autonomous individual. They will not be able to manage their health conditions going forward. So parental education and training underpins good outcomes during this particular transition point. So the key medical aspects around this point is that we, as doctors, need to remember that our children are growing up, and we need to ensure that we're managing their blood transfusion frequency, ensuring that maintaining optimal iron chelation, we're monitoring them appropriately for growth and development, and ensuring that we're monitoring them according to the standards. And there are many international standards on this. So this is traditional transition, aged between 12 and 19, and this is an incredibly difficult time point for everybody. The main things that underpin this are the rapidly evolving change that that child and that family are going through. And there's going to be changes in physical appearance, in emotions, in hormones. That is also tied in with changes in doctors and nurses that are providing care for them between the adult and the pediatric setting. There is a change in schooling environment at the same time. They're moving from primary school into high school education and then into university. And then there are changes in family structures and other support systems around that patient. So how successful you are depends very much on how well you've managed transition point 1. If you do not have a child who is able to take some degree of control of their healthcare, you are going to have a lot of problems when they move into transition point 2, because that's associated with a lot of emotional dysregulation. So key skills that underpin success at this stage, and this is for both parents and the children, and this is what we need to provide, is we need to be listening to them, we need to be reassuring them that this will finish, encouraging them when they're making positive progress, praising them when they're making positive progress, and that includes both parents and the child, and supporting them in their decision making. And this is really important, that we are there as the central point for them to be able to get positive feedback when they need it. There are very important relational aspects at this time, including continuity of care, because they're moving from pediatric doctors to adult doctors. The best way to manage this is to have joint pediatric and adult clinics. So the patient and the parents are seeing both the adult and the pediatric team together simultaneously. Everyone's making a joint decision plan about what to do, and the parents and the patient are able to talk to the team over a number of years as they move into adult services. Flexibility on timing when you move them to adult services is very important. It cannot be a rock-hard time point at the age of 16 or 18. It depends on the level of maturity and the confidence of both the patient and the parents. Seeing children alone is really important. We have to be able to see children alone, to talk to them about how they're feeling without their parents, but likewise we need to be able to see the parents alone to see what challenges they're having with managing their teenage child. So both parents and children need that confidence building. And trust and confidence building really underpins success at this point, and we shouldn't have a judgmental attitude around things that patients or parents say to us. We need to help them navigate this incredibly difficult time. So essential points for us as doctors when we're dealing with transitioning young adults is it's important to remember that puberty needs to happen on time. If you fail to get puberty to happen on time, your child will have psychological issues because they'll be smaller than their peers, they'll not look like everybody else, so they'll have less physical development. That's going to carry a psychological burden. Monitoring the bone age so that we are supporting that transition through puberty is very important, and we mustn't forget that they are going to be poorly compliant to iron chelation therapy and hydroxyurea or transfusion regimes, and education needs to be a critical part of this particular period of time. So transition point 3 is adulthood, and we all think, wow, we're out of the woods, we're done, but actually transition point 3 is when patients, although they are more stable, they are also quite fragile, and it's easy for them to lose control without good support. So you will see better compliance to medication, and they're less likely to miss treatment. You will have patients wanting to develop relationships. You know, they're going to want to get married, have a family. It's very important that you're watching out for pitfalls. What I can say is that I have patients who, particularly my thalassemia girls, they have a very bad habit of choosing bad quality partners and bad quality husbands. And this is all underpinned by their perception that because they've got a chronic health condition, they are not good enough and they're not the same as other women. They are, and then the problem here is that you end up dealing with the trauma of poor relationships with patients, and that can cause major problems as they move through their adult life. So it's very important that you encourage your patients to have good support structures, to value themselves as individuals and humans who are worth having good relationships with, and they should have a good support network of peers both with a hemoglobinopathy and without a hemoglobinopathy. Stability of career and work is very important for patients as they're moving into adult life, and we should encourage them all to have a good education, have a work and a good career-life balance. But there are plenty of pitfalls in this. And one of the biggest problems I have with the adult patients in this particular age group is disclosure. Failure to disclosure of their underlying disease to their friends, to their work colleagues, to their families. And one of my thalassemia patients his best friend does not know that he has thalassemia major. It does not know. And I have plenty of patients who, one of my patients is a doctor, and he refused to tell his employer that he had insulin-dependent diabetes. And I said, well, what if you have a hypoglycemic episode at work? And he was like, well, I won't, because I don't take any insulin when I'm at work. I miss my midday dose. I mean, this leads to out-of-control medication, out-of-control side effects and complications from their underlying disease that they don't want to disclose. And even though that disclosure is an important part of their own safety. So we need to encourage disclosure for patients and reassure them that there's nothing wrong with disclosing that. So stability of routine takes time, and it's very important that you take time to talk to your patients and answer questions. And that will actually build up their confidence in being able to do things. Once they are stable, it doesn't take a lot to throw them out of stability into instability. You know, a breakup in relationships, a long holiday, when they're not taking iron chelation will just mess up their routine. And the presence of exams, the number of doctors I have presenting with heart failure because they've not done iron chelation for 5 months because they're going through exams is ridiculous. So don't ask your patients, are you taking your medication? That's either a yes or a no, they're not lying. Ask them how many doses did they miss last month. Then you'll get an idea of what they're actually doing. Know what's going on in your patient's life. It's really important you know what's happening at work, what the stresses are, what's happening in their family life and what the stresses might be. And then talk to them about how they can prioritize their treatment, because good health underpins their ability to deal with things. And one of the things I always ask patients is, what happens when you forget your medication? You know, what were you doing at the time? What was the driver? Because that actually gives you an idea about helping them how not to forget. So stability of relationships is really important, because parental loss of control when a child moves into the adult setting means that if you've not done stage 1 and 2 of transition properly, you're going to have a completely out of control patient in the adult setting. And that can cause lots of problems. So education about disease and consequences is really critical. And future partners, it's really important that patients understand that their disease is lifelong. They cannot not disclose that they have a health condition. And they, you know, if anyone really cares about them, they will stay with them regardless of what their disease is. So ensuring that they do disclose to partners is really important before the marriage, by the way. Disclosing after the marriage is no good. Breakups and divorces do happen when disclosure doesn't happen. And we have to remember that as our patients get older, they are going to have a lot more responsibility. It's not just their thalassemia, or their sickle cell disease. It's dealing with their wife or their husband, their children, their work. There's many, many more responsibilities around them. And so support networks are really important, both with their own peers, with the underlying disease, to learn about how their peers are coping, but also support networks with colleagues and friends who don't have their disease. Now, university is a time of poor compliance in patients, and it's because quite often patients are not emotionally mature enough to deal with their medication and the academic burden that they have to deal with. But also during work, you know, if you've got an agenda to meet and you have to have a presentation ready by tomorrow, you're going to forget to do all the things that you need to do to look after your health. And this is why disclosure to employers and peers is very important. And, you know, we've all got patients who are workaholics, and environment does impact on patients. We had a sickle cell patient who was previously well, who came into hospital once he got a job. Frequently, almost every week, he would be in hospital with a sickle cell crisis. When we sat him down and said, what's the problem? He said he'd been assigned to work in the chiller counter at the local food store where he was working. And clearly he was going to have a sickle episode. He's walking around in a t-shirt in a freezer. So having your own family is a transition point for patients, and we need to remember that, you know, this is something that they have every right to aspire to. And it's important that we recognize that this is not the same as a normal person going through a pregnancy. It is very difficult, and we need to plan in advance, and patients need to optimize themselves so that they're medically fit to undergo these events. And we need to ensure that male gonadal issues are addressed in advance, particularly issues around sperm counts and spermatogenesis induction if that's needed. And one of the things that females often forget is that they have a biological clock, and I would strongly recommend if they want a baby that they need to get moving before the age of 40, because it's very difficult once they're beyond that to get fertility funding or to get anything else successfully done. So optimal compliance is an amazing thing, because when you have a goal, I want to have a baby, your compliance will be 100%. You are not going to miss a single day of your medication because you're committed to a goal. So knowing what drives your patients makes a huge difference in getting them to do things when you need them to do things. Elderly care, this is something that we all do very badly. And I think that this is because we don't recognize the burden of disease on our patients. I had a patient who was 59 years old, and she and her husband had a conversation, and she came to me to clinic one day and said that she wanted to go to Switzerland to a euthanasia clinic. And I was completely shocked at what she'd said, and I was like, why? And she goes, my life is horrible. Every single day is a struggle. And we forget that this is a transition point when you're moving from a healthy life to old age, and age in thalassemia and sickle patients can be any time after the age of 45. And recognizing the challenges that they have is really important. Thankfully, she didn't go to the euthanasia clinic, and she's now quite a happy lady. But it's important that we think about that. So balance of work, continuing to work or not, balance of treatment burden, the impact of chronic complications on our patients' health is really critical. Back, bone, endocrine, cardiac, liver, neurological, and other damage. Many of the sickle patients have got a lot of neurological damage that they have to deal with as they move into their 40s. And as I said, it's done badly everywhere. So what are the challenges? It's recognizing when treatment and work-life balance and family life and all of these things become too much. And we have to remember that we need to ask about quality of life. We're almost always focused on what's your ferritin doing, what's the albumin-creatinine ratio. We're actually not thinking about what is the impact of your disease on your quality of life. Recognition of the burden of treatment, multiple endocrinopathies, iron chelation, kidney treatment, all of these things have a burden to play. And then there's a lot of stress with our patients as they get into this age group, because they're dealing with elderly parents, they're dealing with young adolescent children, and that is a huge amount of stress for them. So we need to ensure that there are adequate interventions available for them, psychological, social, community, as well as medical interventions. And we shouldn't shy away from palliative care if that is really something that we need to do. So reduce pill burden when you can. It's really important to look at what are your patients taking and reduce what you don't need. Medication reviews, why are you taking it? Do you still need it? Simple things make a big difference. Going to ambulatory glucose monitoring with a Freestyle Libre completely transforms the lives of diabetic patients because they don't have to prick their fingers 6 times a day. Psychological input is really important, and patients needing to learn that they need to be kind to themselves is a really important thing. And physiotherapy and the importance of retaining mobility and flexibility is really important for patients. So what are the support services? Well, I just want to say that good care is not driven by one person. It's a multidisciplinary approach. You have to have really engaged and supportive clinical nurse specialists, psychologists, dietitians, physiotherapists. You need a full team. It takes a village to manage a patient. So good nursing provision, good psychology, physiotherapy, all of these things are absolutely critical, and multidisciplinary care is going to underpin successful outcomes in our patients. And MDT discussions, the decision shouldn't be yours alone. It needs to be an MDT discussion around what is happening with the patient, what can we do to support the patient, and what other interventions we need to do. So I just want to say thank you all very much for listening. It's been my pleasure to be here.
Thank you, Dr. Shah. Excellent talk and excellent timing. I would like to invite all the speakers here to the stage. We have a very tight time, so maybe we have time for one or two questions if there is anybody have questions. Please. So if none, I have a question to Dr. Shah regarding the transition from pediatric to adult. It's a very difficult time for the patient and sometimes even for physician. What do you think the best time and how to make it smooth? We try, I saw your slide about joining clinic. We tried it, but unfortunately it was not so successful. There is some resistance from our adult colleague. So what do you think the best time to do this transition and how to make it smooth?
Yeah, I think, Hello, yeah. So I think that's a really important question because obviously funding impacts on ability to have joint clinics because it's about financial reimbursement and all of these kind of things. So I think my own personal view about when to transition, you have to see how mature your patient and parent is. Are they emotionally able to move over to a new service? And if they are emotionally able to move over to a new service, then you definitely need at least one introductory clinic where you go and join the adult physician in the clinic and do a proper handover. But also make sure that you leave the door open for the patient to come back and have a chat with you if they want to have a chat with you. They may not, it takes time to develop relationships. You've got a long-term health condition, whether it's sickle or whether it's thalassemia, and they trust the pediatricians and they don't know the adult doctors.
Yeah.
And that is a real challenge. So if you can't do a joint clinic, it's really important to have the doors open on the pediatric end, but wait until the patient is emotionally mature enough to move into the adult service because, sometimes you don't have a choice. There's a dead cutoff at the age of 14 or 16 and you just have to move them. But if you're talking to them in advance, we generally start talking to them in advance, about 2 to 3 years in advance, that they're now growing up. They are going to be looked after by adult services, and we kind of emotionally develop some support mechanisms around them so that they can move into the adult service if they need to. My unit in the UK has done combined transition for 15 years. The patients have known me since they were babies, and they've known the pediatrician since they were babies. So when they move into my service, it's not a problem for them.
Okay. Yes. Go ahead. Can you help with the mic?
My question is to Professor Yanaki. I think you touch on it at the end. Given the high cost of ex vivo gene therapy, can you shed a little bit of light on progress being made for in vivo gene therapy, given that these hemoglobinopathies have the highest burden in countries with low resources? What is the progress being made, and do you have a crystal ball to predict when we are likely to see first clinical trials with in vivo gene therapy?
Yeah, thank you for the question. So as I've told you, I think that the future will be the in vivo gene therapy for hemoglobinopathies and even for other HSC disorders. So the progress that's been made includes showing the curing sickle cell disease and thalassemia in mouse models and also in non-human primates. We are not very close to a clinical trial yet. Unfortunately, this means that it will take some time before we will be able to investigate this approach in humans and, of course, later to see an approved gene therapy product for in vivo gene therapy. Not very close, but the proof of concept has been shown, yeah.
Thank you. Please stay. There is some certificate. Dr. Hatun.
Okay, with that, I think we concluded the morning session finally. So please proceed to lunch, second floor, Mazaj restaurant. But we will take 45 minutes for lunch this time. So please be back at 1:45, and then we will kick off with Samiha.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته جميعا. I would like to start by thanking Dr. Hatoun and the organizing committee for their kind invitation. And it's time for us to start the afternoon session, which is one of my favorite because it's related to women's health. Our speaker today is Dr. Kinga Mlansky, whom I've known from McMaster years ago. Dr. Mlansky, she completed her fellowship in maternal fetal medicine in Mount Sinai Hospital in Toronto, and then she joined the maternal fetal medicine department between 2011 and 2025. She established and co-directed a hematology clinic in pregnancy, and recently she moved back to McMaster, where her clinical practice focuses again in hematological disorders of pregnancy. She is holding right now a cross appointment at McMaster University at the rank of professor in the Department of Obstetrics and Gynecology and the Department of Health Research Methods, Evidence and Impact. Both her research and clinical work are focused in hematological disorders in pregnancy, particularly sickle cell disease, thalassemia, as well as thrombosis and thrombocytopenia. It gives me a great pleasure to call Dr. Mlansky to talk to us about a very important subject, which is fertility and pregnancy issues related to inherited blood disorders.
Assalamu alaikum. Good afternoon, everyone. Thank you so much for the invitation, Dr. Hatoun and the organizing committee. It's my pleasure to speak with you today about fertility and pregnancy planning. Maybe. Here we go. So I have a bit of an ambitious agenda for 30 minutes, and so I've tried to focus this a little bit. We'll talk about contraception, fertility challenges, then we'll talk a little bit about genetic screening, very briefly about some implications for various intervention in pregnancy, which I will focus on sickle cell disease, and I will focus this talk on hemoglobinopathy as opposed to inherited bleeding disorders. So, as we've heard through the days yesterday and today, with improved care, we have improved outcome, longer survival, albeit with some comorbidities. More individuals are reaching reproductive age and wanting to start a family, and with that, there can be some disease-specific associated fertility risks as well as pregnancy risks. So when we consider pregnancy planning in this setting, we want to consider contraceptive options as well as fertility, partner screening, counseling, genetic screening and therapy. We want to optimize health, which means assessment of and organ effects of the particular condition, medication review, vaccination update, management of iron chelation status, particularly for thalassemia. I will focus on the first and part of the second column today. I can talk about sickle cell and thalassemia all day, but we have 30 minutes. So let's start with contraception. So in thalassemia, certainly outcomes are better with transfusion, iron chelation, and transplant, but in order for pregnancy outcomes to be optimal, we need to make sure that we've achieved iron status optimization. A lot of the adverse outcomes, as we all know, including heart failure and arrhythmia, will happen with iron overload states, and particularly myocardial iron overload. So this is key, and until we achieve this, it's more perilous to plan a pregnancy or to have an unanticipated one, in which case we want to potentially have contraception options in place. And for thalassemia, there really aren't any absolute contraindications as far as the method of contraception that is chosen. This is a little bit different for sickle cell disease. I wanted to briefly go over this summary of the medical eligibility, or MEC, criteria for contraception from the US. As you can see here, they are graded based on risk. And as you can see on the right, this is DMPA, which is dipomedroxyprogesterone acetate, a progesterone type of injectable contraception, which in 2016 was ranked as no restriction and was changed to between 2 and 3 in the most recent iteration. And the panel suggested that this is because there is somewhat increased risk of thrombosis with this medication, and that patients with sickle cell disease, certainly as we all know, have an increased risk of thrombosis and stroke. And I'll come back to that in a second. When we look at combined hormonal contraception, which is estrogen plus progesterone, which is the most commonly used form of contraception, this, as you can see in 2016, was rated as advantages generally outweigh the risks. However, it was changed with the most recent iteration to unacceptable health risk and should not be used. And again, the reason for this, cited by the panel, is the fact that there is an increased risk of thrombosis and stroke in sickle cell disease. However, the challenge I find here is that we are removing a very reliable form of contraception from these patients. And when we look at these risks, they are relative to no contraception. And so what we have to factor in is that pregnancy is a much higher estrogen state, much more likely to be associated with complications. And if we have unplanned pregnancies because we've taken away a very reliable form of contraception, then I'm not sure we're necessarily doing the right thing. So I think it does bear having a individualized patient discussion. Part of the reason I feel this way with this recommendation is that this is the evidence table on which this recommendation was changed. There is no new evidence here per se, and as you can see, the risk of bias is very high, the numbers are low, and the certainty of evidence is very low. And yet, despite this, it was changed from number 2 to number 4, do not use. I want to draw your attention to a study which was done perhaps concurrently with the review, and I don't believe it was included in that review. It is a study looking at over 7,000 patients comparing combined hormonal contraception and progesterone-only contraception, looking at thromboembolism risk, so the risk of venous thrombosis as well as arterial thrombosis. And as you can see here, this study did not find a difference in thrombotic risk between combined hormonal contraception and progesterone-only contraception. And interestingly, they've also made comparisons within these groups, and what they found is that the risk of thromboembolism was increased with transdermal or patch type combined hormonal contraception, but it was not as high with other types of combined hormonal contraception. Conversely, the risks were the same regardless of which progesterone-only contraception was used. So let's move on to fertility. When we look at thalassemia, any fertility challenges are mostly driven by hypothalamic pituitary axis challenges, which can be precipitated or are often precipitated by excess iron deposition, as we all know, which affects sex hormone production, development of secondary sex characteristics, and in females, menstruation and ovulation. In sickle cell disease, women are susceptible to similar causes and risks of infertility as the general population, of course, but in addition, they have disease-specific risks. And so there are unfortunately no definitive studies of fertility in sickle cell disease, but there are high rates of self-reported infertility in these patients. What we are finding is that the window of fertility is shorter in females with sickle cell disease. So onset of menstruation
is delayed up to 2.5 years almost, and menopause may occur 4 to 5 years earlier than in the general population. What we also know is, as we've heard, there's end organ effects from sickle cell disease throughout the body, and the ovaries are indeed an end organ as well and are susceptible to sickle cell complications. What we're learning is that anti-Mullerian hormone, which is a biomarker of ovarian follicle reserve, is actually declines actually earlier and shows lower ovarian reserves in sickle cell disease. And diminished ovarian reserve is predictive of response to fertility treatment and is a consideration for fertility treatment outside of sickle cell disease. We're also finding out that diminished ovarian reserve has been identified in up to 25% of patients with sickle cell disease under the age of 31, and it has been also associated to a degree with use of hydroxyurea. However, clinical infertility is not yet definitively associated with these findings, so there certainly is more need for more research. But when we consider disease-modifying therapies such as hydroxyurea, of course we know the positive effects that hydroxyurea therapy can have on stabilization of sickle cell disease, and we don't yet know whether hydroxyurea is causally related to ovarian reserve or whether it's actually a proxy for sickle cell associated risk for diminished ovarian reserve. So this question really does require further study, but it's just something to keep in mind. The other thing that we need to consider is that, as we've heard through the days, certainly there is more move towards HSCT as well as gene therapy, and these therapies do require conditioning regimens which can result in infertility. So when women are thinking of undergoing these treatments, fertility preservation discussions are really key. And so again, with fertility treatment, from the thalassemia perspective, is the iron chelation that's the most important initially. And treatment can involve hormone replacement therapy, gonadotrophin therapy, as well as in vitro fertilization. But when we're going towards consideration of in vitro fertilization, one of the things that we need to keep in mind is that it can and does, in increasing rates, result in multiple pregnancies. We've already talked about the fact that pregnancy is a high-risk event for these individuals, and when we add twins or triplets, that becomes much more challenging. So with fertility preservation, there are a number of choices. For women, this may take the form of ovarian cryopreservation. For men who have undergone puberty, there can be sperm cryopreservation. And of course, if there is a partner, there can be embryo cryopreservation. And I'll come back a little bit to the process in just a minute. But the next topic we want to consider is genetic counseling. And so the region here, as you all are familiar with, has a premarital screening program, which is mandatory, is my understanding. And then there's a genetic counseling component. So this was very interesting for me, and these studies may be familiar to you, in which case thank you for letting me learn. But there was a study done in the region looking at 182 couples to assess the relationship between socio-demographic characteristics, knowledge, and cultural factors with respect to decision for at-risk marriage after undergoing premarital counseling. And interestingly, you can see the factors here which led to the decision to not proceed with at-risk marriage. And what I found interesting is that participants with lower than secondary education were actually less likely to proceed with at-risk marriage than individuals with higher education. Now here we see what factors influence the decision to indeed proceed with at-risk marriage.
And the top factors were looking at a knowledge gap where sickle cell and thalassemia were thought to be not serious diseases, that the risk of having an affected child was very low, and that couples knew others with incompatible results who had healthy children. From the socio-demographic perspective, there was some couples expressed a preference for consanguineous marriage, and there was a high prevalence of hemoglobinopathies linked to consanguineous marriage, with families believing that this type of marriage will strengthen their attachment to each other. The next factor was that participants suggested that it was their fate and they must accept it, and talked about the authors talked about the importance of involving religious leaders and communities to participate in health education to try and influence decisions. And finally, at-risk marriage was more likely when abnormal results were received when already in a committed relationship, where there were wedding plans already in place and couples were not willing to break those plans and commitments. So early testing in high school and university and prior to engagement was thought to potentially be more beneficial. And finally, some couples felt that they would proceed with at-risk marriage because they could have IVF to have healthy children. There was an economic analysis of premarital screening that was done, which looked at 300,000 cases with a decision analysis and looked at the annual cost for children with the probability of sickle cell disease, where the screening arm had a cost of about $11 million US, and the non-screening arm about $41 million US. So there was a 73% reduction in healthcare spending with premarital screening, and there was an absolute difference of about $30 million. So what about pre-implantation genetic testing? So this is a process. It's a fairly invasive process that starts with an assisted reproductive technology specialist, assessment by a genetics specialist, preparation and diagnostic protocols by a PGD laboratory, ovarian stimulation, oocyte retrieval, fertilization, embryo culture, genetic analysis, preparation of the embryo for transfer back, finally establishment of pregnancy, seeing if it'll actually work, prenatal diagnosis, and neonatal follow-up. It is not an easy process. The benefits are that you have an unaffected embryo that is implanted, removing the need for consideration of pregnancy termination. The drawbacks are that it's invasive, it takes an emotional toll often on the couples, and it's expensive. So there was a study done in the region looking at the assessment of attitudes towards the use of pre-implantation genetic testing in Riyadh, and about 230 participants took part. Only 28% of them had prior experience with pre-implantation genetic testing. Knowing someone with prior PGT experience was associated with more favorable attitudes. And general public support for screening was around 81% for diseases fatal in the first year of life, 74% for diseases that cause lifelong disability, and about 75% for diseases that may not occur until later in life. So if someone isn't ready for pre-implantation genetic testing or does not want to take that route, the other options they have once they achieve a pregnancy is to have non-invasive prenatal testing or invasive prenatal testing with chorionic villus sampling or amniocentesis. So non-invasive prenatal testing looks at cell-free fetal DNA and maternal bloodstream from 9 weeks of gestation, and it is used fairly widely for aneuploidy detection in the form of trisomy 21, 18, and 13, as well as some
microdeletions and duplications in sex assessment. And invasive testing, again, is CVS, which can be done between 10 and 13 weeks, and amniocentesis, which can be done at greater than 15 weeks, but carry very small risks of pregnancy loss. When we look at NIPT and thalassemia, the accuracy can vary based on gestational age, fetal fraction, a specific mutation, and laboratory parameters. And so there are potentials for inconclusive tests, for false positives and false negatives, and it really isn't yet a replacement for invasive testing. But there is ongoing work being done, which is very promising. So this newly published study looked at 93 families at risk for thalassemia with various genetic variants, and for them, they had 98% success rate in terms of actually having a result and 100% concordance with invasive testing, starting at 8 weeks of gestation. So we're moving in the direction of potentially being able to offer it with good accuracy. When we consider NIPT and sickle cell disease, there was a meta-analysis looking at 6 studies that met inclusion criteria, and what they found was that the correct diagnosis was reached in about 81%, and incorrect diagnosis still in about 19%. So again, not yet a replacement for invasive testing. There was a study again that looked at prenatal diagnosis and pregnancy termination practices among highly consanguineous couples in Saudi Arabia, looking at over 2,500 participants. And the influencing factors were education, history of having an affected infant, prior knowledge, and religious beliefs. Non-consanguineous couples had a more favorable attitude towards termination of pregnancy than did consanguineous couples. 68% would consider prenatal diagnosis, 33% would consider termination of pregnancy, and another 30% depending on severity in this study. Similarly, another study looked at prenatal testing and termination of pregnancy acceptance and attitudes from medical students and healthcare professionals, where invasive testing were found to be most acceptable as far as prenatal diagnosis, because again, non-invasive prenatal testing were felt to be too non-specific. So 82% of respondents accepted and encouraged prenatal diagnosis in their patients when appropriate. 8% were against having this or offering this test. 48% favored termination of pregnancy discussions when the fetus had severe disease, and 34% were against having those discussions. So once we get to the stage of actually achieving a pregnancy, I will just speak very briefly about certain considerations, because as we have heard and we know, sickle cell disease, pregnancy and sickle cell disease specifically is associated with higher rates of sickle cell disease specific complications, as you can see here, as well as pregnancy-related complications. So maternal mortality, preeclampsia, growth restriction, preterm birth, and perinatal mortality are all higher, as well as I mentioned, sickle cell disease-related complications. So one of the higher rates of complications comes in the form of preeclampsia. And so there has been work done around how we assess the risk of preeclampsia in pregnancy, and particularly in sickle cell pregnancy. We did a study looking at placental pathology and the performance of mid-trimester ultrasound, and specifically the assessment of uterine artery Dopplers, where we would expect the uterine artery flow, which is normally outside of pregnancy a high resistance waveform, such as the one on the bottom, to transform into a low resistance flow, whereby this is associated with lower rates of preeclampsia. And we found that the presence of high resistance uterine flow at mid-trimester was strongly associated with small for gestational age and preterm birth, and with abnormal placental findings such as maternal vascular malperfusion, which is a feature of placental pathology that has been linked to these conditions outside of sickle cell disease in pregnant patients. So certainly that is one way we know how to risk stratify, but we wondered if we could also look at the utility of placental growth factor. So outside of pregnancy, placental growth factor is produced by erythroid cells and is typically undetectable. But in pregnancy, PLGF is produced by the trophoblasts, so placental cells, and it peaks at 28 to 30 weeks and then starts to decline, and outside of sickle cell has been shown to be a powerful diagnostic tool with respect to preeclampsia. Now, the challenge is that with sickle cell disease, expression of PLGF outside of pregnancy is upregulated, and so too we wondered if this would be the case in pregnancy, and wondered whether that would impact our ability to use this as a predictor of preeclampsia in individuals with sickle cell disease. And what we found, in fact, is that it performed just as well in patients with sickle cell disease as in patients without sickle cell disease, and at 20 to 24 weeks, it had 100% sensitivity and specificity at a cutoff of less than 100 picograms per mil, which is the same cutoff as we would use outside of sickle cell disease to predict early onset severe preeclampsia. So what do we use to help decrease the risk of preeclampsia? Well, outside of sickle cell disease, there is evidence from a nice randomized controlled trial, which was published in the New England Journal, looking at at low-dose aspirin. In this study, the dose was 150 milligrams at decreasing the risk of preeclampsia, and you can see here that it was significantly reduced in those on ASA to 1.6% from 4.3%, and the rates of preeclampsia in sickle cell disease are around 8%. We don't have yet a study looking specifically at whether this performs the same way in sickle cell disease. However, there is a study in progress which should be published, I hope, in not too long a time. But in the meantime, I think across guidelines, we have certainly used low-dose ASA, extrapolating the findings to sickle cell disease. Very briefly on opioids. There are maternal concerns around and fetal, mothers are concerned about the fetal and neonatal effects and sometimes avoid the use of opioids and therefore treat their vaso-occlusive events inadequately. And there's often reluctance from providers around concerns for addictions, and this may vary obviously depending on the region we live in. And concerns around neonatal abstinence syndrome, or what we should more closely refer to as neonatal opioid withdrawal syndrome, and sometimes leads to underprescribing. But there are consequences to this, and this may in fact be harmful because it can potentially lead to progression to acute chest syndrome and higher both maternal and fetal mortality. The American College of Obstetrics and Gynecology, in fact, came with a committee opinion on opioid use in pregnancy and suggests that pregnancy should not be a reason to avoid treating acute pain because of concern for opioid withdrawal in misuse or withdrawal in neonates, in that healthcare providers should not hesitate to prescribe this under the right circumstances based on these concerns alone. If we consider hydroxyurea, traditionally we stop hydroxyurea for pregnancy, and part of the reason for this is that there have been animal models suggesting teratogenicity of the medication. The thing to keep in mind is that human doses are about 1/5 to 1/10 of the teratogenic animal doses, and there is a different route of administration for hydroxyurea in humans, which is oral, as opposed to the intravenous or intraperitoneal routes in the animal models. There have been registries and studies suggesting that there is no teratogenic change in pregnancies ending in birth, regardless of whether hydroxyurea is taken by the mother or the father. And there were no delays thus far in developmental milestones with use of hydroxyurea at conception, sometime during gestation, or throughout pregnancy. That is not to say that there is enough data there to give every pregnant person a hydroxyurea in pregnancy. However, we do have to consider that there are certain individuals who have contraindications to transfusion, potentially alloimmunization with multiple antibodies, and in those individuals, more consensus statements and guidelines are now suggesting that there is room for individualized discussion around whether this is a medication that should be reintroduced in pregnancy if there are no other options. I'm almost near the end. I wanted to briefly just touch on transfusion. We've heard again around transfusion preparation, and so patients with sickle cell disease need a phenotype and genotype for the red cells. If there are antibodies, the partner's phenotype needs to be checked to determine the risk of hemolytic disease of the fetus and newborn. Patients without antibodies are matched for Rh, Ce, and Cal, and those with antibodies are matched for, have an extended match for other antibodies. We did a study looking at prophylactic transfusion in sickle cell disease, where indeed we were able to show that maternal mortality, perinatal mortality, vaso-occlusive pain, pulmonary complications, and pulmonary embolisms are reduced with prophylactic transfusion. Interestingly, placentally mediated outcomes such as preeclampsia or fetal growth restriction were not affected. And so we hypothesized that the reason for this is because in these studies, prophylactic transfusion was typically started for pregnancy complications mid to later pregnancy, and so we sort of miss the boat when that happens on optimal placental development, just as happens with low-dose aspirin, which really for benefit needs to be started before 16 weeks of gestation. And so indeed there was a study, a small study done in Italy looking at 46 patients with severe sickle cell related complications and starting prophylactic transfusion from 5 to 6 weeks of gestation every 3 to 4 weeks until delivery. And in this study, in this group, there were no vaso-occlusive event hospitalizations, no preeclampsia, and the fetal losses that happened in 3 patients were all referred late and started transfusions at greater than 20 weeks. So why not transfuse everybody? Well, obviously, one of the reasons is that transfusions have risk, as we know. They can lead to alloimmunization, transfusion reactions, iron overload. There's cost and convenience. Also because the studies that we talked about are not huge samples, and they do have some methodologic limitations. The other reason is that while 71% will have adverse maternal outcomes and 45% will have adverse fetal outcomes, at least in our cohort, 30% had uncomplicated pregnancy. And if we expose all of these women to prophylactic transfusion, they would bear the burden of harm without really any benefit. And so one of our goals is to develop a risk prediction model looking at screening for the highest risk individuals who actually would benefit for targeted therapy, whether it be transfusion or other therapies in the future, or inclusion in trials of therapies to try and decrease risk and not increase the risk of harm in those who don't need it. We've published this as a single center cohort, but are now in process of doing a multi-center model validation and refitting. 2 more slides and I'm done. So postpartum, we're not done with complications of sickle cell. We looked at 202 pregnancies and found and looked at composite outcome for immediate postpartum complications consisting of vaso-occlusive events, acute chest syndrome, infection, or new onset hypoxia. And we found that in the hemoglobin SS, hemoglobin S beta null group, the composite event was in 51%, and in S beta plus group, the composite event was 19%. So there was a genotype effect there. However, on multivariable regression, the two factors that actually were associated with a higher risk of immediate postpartum complications were hypoxia during pregnancy and an unscheduled cesarean section. And so certainly more work needs to be done to figure out if treatment of hypoxia in pregnancy can decrease these rates of adverse outcomes postpartum, and whether we can have a way to choose to predict risk of ending up with an unscheduled cesarean and try and mitigate that risk. In terms of breastfeeding and disease-modifying therapy, in terms of thalassemia, desferal can be used safely if breastfeeding is in place and it needs to be reinitiated. And for sickle cell disease, there is a nice study now by Dr. Ware's group looking at hydroxyurea transfer into breast milk with a relative infant dose of 3.4, which is below the recommended 5 to 10% safety threshold. And if the next feed is actually discarded, so the so-called pump and dump method, the HU transferred through breast milk is further reduced by about 50%. So infant exposure is less than 1 milligram per kilogram per day. And so really breastfeeding can proceed with hydroxyurea reinitiation postpartum. I have not touched on venous thromboembolism, which is another complication in pregnancy. There are guidelines that suggest potentially considering low molecular weight heparin thromboprophylaxis later in pregnancy and certainly postpartum, and that is our practice with respect to postpartum thromboprophylaxis. Thank you.
Assalamu alaikum.
Thank you, Dr. Samiha. Thank you to Dr. Hatoun, his group for this keep going meeting. And this is a special session about the World Federation of Hemophilia, and it is my great pleasure to have this session and to share it with you. We have two eminent speakers going to talk about or highlight about the WFH, World Federation of Hemophilia. Mr. Cesar Gradio, who was selected as the president of WFH 2020. And he is originally from Venezuela, and he has a lot of work as advocacy in Venezuela Association of Hemophilia and WFH and all over the world. His son, he is a hemophilia patient, and from there he going to globally educate and taking care of the hemophilia patient. And Rana Saifi, she is the Middle East or East Mediterranean Regional Program Manager, and she has 30 years experience in international development policy and leadership. And personally, I know Rana for the last maybe 5 or 6 years, and I know that she did a lot for the Middle East countries, and I am so happy that we shared together the Hemnet 2 years ago in Jeddah. Rana, she is trilingual. I don't know why they have wrote it for me here, Arabic, English, and French. So, بنوفي رنا سيزار دي أرابيا السعودية.
Thank you, Doctor, for these kind words and the welcome. Good afternoon, everybody. So thank you for joining us. Stay there even after the big launch. So I want to thank the organizer, the Minister of Health. The organizer asked me to talk about the global collaboration to enhance hemophilia management. Actually, that is one part of the role of the World Federation of Hemophilia. So just briefly, World Federation of Hemophilia, we gather 151 patient organizations, national member organizations, so that means 151 countries. We were born in 1963, even we are an organization with more than 60 years, so we are still young because every 5 years we prepare a new strategy, plan strategy. Our vision, treatment for all, obviously is very challenging. So how is possible to give treatment to all people with hemophilia and other bleeding disorder? The idea and the vision is at least the best treatment, available treatment possible in each country. So that means that we cover, regardless where they live, the gender, culture, social position. So we consider all patients in any part of the world. Our mission is to improve and sustain. It's not just to obtain the benefit to this patient get the treatment, is to be sustainable during their life. We are recognized by WHO, so that is important. During many years we have had very good relationship with this important international organization. Actually, during many years we published our publication with the logo of the WHO, and recently the relationship has been stronger, and for sure Rana will explain even deeper about this topic, but that is a recognition, our reputation as an international organization. So we have 8 regional managers. This is important because those managers are living specific in the regions that we want to be focused on. So that helps us to get better information rapidly, and it's possible to interpret the needs of each region. The hemophilia is living a very gold moment in the life. At the moment, the hemophilia has been improving in terms of the available therapies, available medicines, innovators are coming even more. So we have to recognize that thanks to our treatment guidelines, third edition was possible to establish and to be clear that the prophylaxis is the gold standard of the care of any person with hemophilia. So the idea is to anticipate, to avoid any kind of bleed. Is the best treatment. We have to recognize in many countries, Saudi Arabia is one of them, that is in practice the clinical trials. That is something in the past was specific for just for developed countries. Today is common to have in every other countries. The performance of increasingly complex invasive procedure, so the new therapy establish or give the opportunity to patients just don't be attacked. That is the name of the qualification from the patient. Intravenous could be subcutaneous, so that help the patient to suffer less about this complication. And finally, the gene therapy looks like the solution, moreover, in those countries with huge population. Sadly, at the moment, several pharmaceutical companies abandon this process because it obviously has been very expensive and not enough received by the government in order to purchase. And one of the aspects is that at the moment there are many other options for the people with hemophilia and other bleeding disorders as well. So that promise that the patient currently have had and have very good treatment and the possibility while gene therapy gain a strong position. This is part of my explanation. So as factor replacement therapy, you have the standard half-life as plasma-derived, the standard half-life as recombinant, the extended half-life as recombinant, and ultra half-life as recombinant. So in this case, for example, the patient, because is convinced that the prophylaxis is the treatment, with the standard half-life, maybe it's 2 or 3 times a week in order to keep the prophylaxis. But with ultra half-life, it's possible once a month or maybe every 3 weeks. So that helps to the patient to acquire a better quality of life. The other options now, the mimetics, for example, at the moment are introducing at the market, and rebalancing agents is coming as well. So as I told you, the patient have a big portfolio in order to be very good treatment. And finally, the gene therapy that is more the hope for the future. Other aspect that is included and is something very important for the hemophilia community is that we understood that the women deserve to be diagnosed and deserve to be treated. So, and we established that 6 years ago that the women and girls, they can be considered like a patient with hemophilia as well, or at least other bleeding disorders. One of the initiatives that when the woman, of course, is capacity, is not easy to break that stigma that the woman was usually the carrier of this complication, and now we are recognizing that she deserves to be a patient, she deserves to be treated as well. So that means, and that need awareness, we need to raise more awareness, and maybe we have to include to consider the participation from the gynecologists as part of the comprehensive care team. In the past, never we thought that the gynecology must be considered. And finally, we are creating a data collection about that, because during many years we just consider the data coming related to men. So now, I mean the last 6 years, this has been part of the challenge of the WFH, helping to understand from everywhere that the women deserve to be treated, deserve to be diagnosed. After has been successful these last 8 years, thanks to the appear the innovators, we have been discovering that the patient is not just bleed, at the same time suffer apparently with but his performance and his life, the mental health is something of the aspect that we need to consider. So this psychosocial aspect, we need to be deeper in that case. It's not the same when we compare someone who has prophylaxis and some patient who has no prophylaxis. Or for example, an adult with 35 years old or 40 years old, for example, we had a patient this morning here. In several cases, for example, the patient, even under gene therapy, maybe he doesn't want to be total cure, because during 40 years he has been a patient with hemophilia. So that is very important for the future. It's one of the challenges that we have now. So it's new for us. At the moment it's a fashion, a part of the study of the WFH, and it's a new challenge for the hemophilia community as well. As I told you, every 5 years we design a strategic plans. So the next one, of course, 2026 to 2030, at the moment is a revision. We have to decide at least in a week our new strategic plan. What happened with this? Okay. So just briefly to explain, obviously define improves the standard of care, humanitarian aid donation. So this donation is part of the program we call humanitarian aid program. It's not like a Caritas action. The donation of our products, medicines, when we give any country that maybe was almost impossible to give treatment for them, has been possible to treat the healthcare professional, has been possible to convince the authority is the benefit of the companies to adopt those therapies, so they acquire a commitment to purchase. Something happened with the projection. The strength our global advocacy, I explained that our work with WHO has been important to convince and to make influence in public health policies globally. Integrate the artificial intelligence is one of the challenges that we had to try to advance in this. It's new for us, but help us to be updated. And develop the national member organizations. So that means to professionalize, to teach, to train the capacity to be leading and trying to convince, making advocacy in front of the authorities. So that is part of our strategy. The World Federation of Hemophilia model is based on using the treatment guidelines, the third edition. I'm sorry with this animated. It's not to me. Well, so the treatment guidelines, as I told you, establish the appropriate treatment, and everybody must be clear. That's been possible to convince, and part of this treatment has been influencing different guidelines and local in different countries. The data collection is for us the most important aspect that we need to convince based on scientific evidence. The advocacy is part of the challenge every day to convince the government, the health authority, the companies to give the treatment, appropriate treatment for patients. Collaboration with different international organizations, not just working about hemophilia, working, for example, with sickle cell, with other illness. And last but not least, the humanitarian aid has served as part of the tool in order to give teaching, practice, training to healthcare professionals in those countries. I want to highlight that the World Federation work address to the government, to the authority, not just with single patient or single authorities. A hospital is addressed to the nation, to the government, to the state. In this case, we signed an MOU with Egypt. The next one, the letter of intention in 2024, Dr. Hatoun was present there. And yesterday, as you were a witness, we signed the MOU. The data, I want to make emphasis of this because this has been part of our strength of the WFA. We have several sources of information. One is the annual global survey. Usually this information is sent by the national member organization, could be combined with the Hemophilia Treatment Center in several countries. For example, this information is sent by the Ministry of Health and is related to the number of patients with hemophilia A, hemophilia B, von Willebrand. So during the last 22 years has been given very important information in order to design strategies and how to approach to each region or country. The gene therapy register is the new register, so very important to receive how those patients have been improving and how affect. Actually, we have the information of several countries directly, all right? And WBDR, World Bleeding Disorder Register. This information is sent by the hospital. So each patient is a number, it's totally confidential, the information, and that gives us deeper information. For example, what kind of the treatment is appropriate for that patient. So if we combine these four sources of information, including my WBDR, is the patient in sending the information himself or herself. So it's possible to design a specific strategy tailored to specific regions or countries. According to the last prevalence, apparently new, since 2019, 20.9 people with hemophilia amid 100,000 males is estimated to be a patient with hemophilia. Finally, that means that we just have registered 31% of these estimated people. You can see the graphic, how has been sustainable. Obviously, hemophilia A and B has been the sector has increased. Von Willebrand disease in the last 5 years has increased 25%, so it's very successful, overpassed our projection. Here, I want to share with you the position of the Eastern Mediterranean, 42%. I insist, I don't know these glitches. Obviously, Europe, 85%, America, the second one, whole Americas, North, Center, and South. But Eastern Mediterranean, the third position in terms of percentage. I think that is possible to increase this number. This is in 2024, according to the information sent by each country. You can see, for example, the position in each country. Saudi Arabia is 46%, so it's over the media. I am convinced that this number is possible to be higher. In several countries, it's not just to diagnose, it's to gather the right information, accurate information, and try to avoid overlap or double information or fake information. But this graphic is useful in order to see where we are. Specific Saudi Arabia, well, at the beginning of the annual global survey, the annual global survey has been during the last 22 years. So you can see at the beginning several times interrupted, maybe failures, but since 2020, you notice that Saudi Arabia has been given sustainable information about the number of people with hemophilia, von Willebrand disease, and other bleeding disorder, which is the grade bar. In this graphic, we can see, for example, the patient with hemophilia A is the major sector versus the factor VIII consumption. So the red line is the diagnosed, the register properly. You can see up and down, that we can interpret this very good information. This year was no information, other year insist information, but if you see the tender has been to increase and almost a similar reaction with the blue line is purchase. The green line at the bottom is our factor donated as part of the humanitarian aid program. So that is the graphic until 2024, how is the performance of this. And when Eastern Mediterranean, a similar graphic, the same. The red line is reflect the diagnosed, has been increasing in the last 5-6 years, so has been possible to acquire from the countries to give information every year, so that helped to be sustainable in that information. But the blue line reflects the moment that each country has purchased or not, or decreased the purchase. In terms of the per capita consumption, again, you can see the neighborhood. Bahrain, something extremely high, is something similar than Sweden or Poland or any the north countries in Europe. So Qatar is similar as well. Saudi Arabia, I don't see Saudi Arabia. The fourth. Okay. So, well, that is something the same. It's possible to increase the information and the experience our treater has been that depending on the quantity per capita, the patient could have prophylaxis, could have a better quality of life. So 4 units per capita was considered for prophylaxis. But the last moment in the criteria of the treater is how many bleeds a year. So if someone who has prophylaxis and bleed more than 3 times a year, if something happened with that treatment, it means it's not the appropriate treatment. The idea and the objective is to have 0 bleeds, 1, 2, maybe 3. More than that, something have to consider the hematology and how it's possible to change the treatment. Saudi Arabia again, and I invite you to speculate with this graphic why even has been sustained increasing the register of patients go down the consumption of factor A. Factor A, I interpret that maybe is replaced by the use of emicizumab. That is my interpretation, but it could be possible. So the idea is to interpret these graphics because it's useful in order to prepare any strategy. The other source that I want to highlight is the WBDR, so World Bleeding Disorder Register. We have a hemophilia treatment center in 53 countries that I insist just the hospital is who send confidential information, totally clinician aspect, 135 hemophilia treatment center, more than 70,000, more than 18,000 people with hemophilia has been sending information that could be useful for our strategy. Well, I hope that you can visit us in April 19, 22 in Kuala Lumpur, our World Congress, so it will be possible to see this reality even deeper and, of course, to learn even more. Now, I want to invite to my colleague, Rana Seifi, to the floor. For sure, I'm not sure, the same that Dr. Taragua, I'm not sure if she's speaking Arabic or English or French. Thank you.
Assalamu alaikum. First of all, it's a great honor to be here, and thank you for staying on to day 3 at 3:10. I think the room is cold enough for us to still be alert, so thank you very much for staying with us. Thank you very much, Dr. Hatoun and the Ministry of Health, for the very kind invitation. It's an honor and a privilege to participate again this year in the Inherited Blood Disorders Summit. But above all, thank you for all the fantastic work that you do in the Blood Disorders Department. I know how hard you personally and the team work, and we're extremely honored to be collaborating with you. We're also extremely privileged to have signed the MOU yesterday with Dr. Hatoun through the partnership that Cesar, our president, and Dr. Hatoun have signed. Cesar covered most of the points that we're going to cover. Before I proceed, want to make a small comment because for the WFH, We do give a lot of importance to data, of course, as you've seen. We have multiple kinds of registries, and we do recognize some of the data limitations. So for the annual global survey, as Cesar explained, this is data that is provided by the patient organization. It's not official data. It could sometimes be one-center data. It could sometimes be incomplete. And that is why we would like to have a discussion about how we can make that data a bit more complete. But that is something which we could tackle later, perhaps. But just to illustrate that the data that we have from the annual global survey does have limitations in the nature of the annual global survey itself. In the WBDR, the data is extremely precise because it's medical data coming from the hemophilia treatment centers who follow the patients each time they visit the center. So it is concrete data from the HTCs themselves associated with the MyWBDR, of course, which complements that by data entered by the patients themselves. So just a note before we proceed. Now, because our president covered most of the points, I'll just tackle two very other angles of our work. The first one is the partnership and collaboration that we have been having with the World Health Organization on a couple of key issues. One of them is the essential medicines list, and another one is discussion with member states about potential advocacy at the global level in terms of the adoption of a resolution specific to hemophilia. The other point that I want to tackle briefly, if we have time, and I'll monitor the time, is the context behind the shared decision-making tool that Dr. Hatil very kindly touched upon yesterday. So without further ado, I'll proceed to our work with the World Health Organization. And just to explain again, to remind you that when Cesar presented, he said that the WHO has non-state actor status with the WHO since 1969. And we've been collaborating closely with them. Most recently, in the World Health Assembly in Geneva, we've collaborated with them last year to organize multiple side events. I cannot see the screen from here, so maybe I need to move sideways. Let me see if I can do that. Okay, so we participated with them last year through multiple initiatives. One was a side event which was co-sponsored with, this was co-sponsored, yes, with the NCD Alliance. It was about global health equity, a shared responsibility in addressing NCD's burden for all, including migrants and refugees, and it was with the government of Egypt, actually, with whom we have also very strong collaboration. We've also co-hosted a side event with Rare Disease International to highlight their milestone resolution, which was adopted last year. We joined IAPO, NCD Alliance, and other civil society organizations to advocate for accelerating progress towards universal health coverage, which is very important as governments move towards privatizing care and assigning premiums also. So it's quite important to keep the hemophilia and bleeding disorders high up on that agenda. And we then co-sponsored a side event on translating real-world evidence into policy and practice on bleeding disorders. The more important part of collaboration, apart from those side events, was the revisions that the WHO has recently made to their essential medicines list and essential medicines list for children. They have two. And within those, they have a complementary list and they have a core list. And we were extremely concerned that pathogen and non-pathogen reduced cryo was listed as an indication for hemophilia treatment. There are many risks associated with that. So our collaboration with them was to add more modern treatments to the essential medicines list, to the core list, and specifically bispecific antibodies. Emicizumab was added to the core list, and also recombinant factor 8 and factor 9. These were the additions. The revisions to the list included the transfer of plasma-derived factor 8 and factor 9 clotting factor concentrates from the complementary list to the core list, and the addition also of desmopressin, which is quite important for mild to moderate hemophilia and certain von Willebrand disease, particularly type 1. And then the third change to the essential medicines list was the removal of pathogen-reduced and non-pathogen-reduced cryoprecipitate as an indicator for hemophilia. It could stay on the list as an indication for other diseases, but for hemophilia there are other treatment options that we consider to be safer. So we were very pleased with that change. And the final change was the removal of factor 9 complex as a therapeutic alternative to factor 9 clotting factor concentrates. The second aspect of collaboration with the WHO is the landmark decision by the executive board to, is my time up? Is it? Okay, I didn't realize that, okay. I'll finish very quickly on this. The executive board last week agreed a decision to ask the World Health Assembly in May to adopt a resolution on hemophilia. And this was led by the government of Armenia and supported by many other governments from our region, Egypt and Morocco in particular. And it's something which looks at the whole aspect of hemophilia, from improved diagnosis to equitable access to care, to the recognition of World Hemophilia Day in particular, which would give it much more prominence, and also the establishment of consultative mechanisms for engagement with local bleeding disorders organizations. The next step on that is the discussion itself in May at the World Health Assembly, and we are hopeful that this will pass. Just very quickly, if you give me 2 minutes, Dr. Tarawa, because we had to combine both presentations. Extremely quickly, the context for the shared decision-making tool that Dr. Hatil touched upon is the principle of multidisciplinary care and the patient at the center of that. And this aligns closely with the MOHJA principle. So we commend MOHJA for putting the patients also at the center. And then there is a recommendation in particular to work on educating the patients and their caregivers, because that would then facilitate their discussion as better informed dialogue with their healthcare professionals. The shared decision-making tool has fact sheets and videos that allow the patients to receive the information they need, and it's something which we believe increases the collaboration and trust between the patients and the doctors, but it's also something which increases adherence by the patients to their treatment and improves their satisfaction. Just a note of caution, the shared decision-making tool is of course evidence-based and updated regularly, but it is not something which will allow everybody to have the treatments listed within it, because not everybody has access to those treatments. The second thing that the shared decision-making tool will do is educate the patients, but it will not tell the patients which option is best for them. That is a discussion that the doctors and patients have between them. And it does not mean that it's a single decision. I think that's all from me. Thank you very much.
Thank you, Cesar Rana. Unfortunately, we don't have enough time for discussion, but just a small comment about the data coming for Saudi Arabia. As Rana said, there is a limitation of the data, but actually in Saudi Arabia, we have exceeded 70+% of identification, and the factor consumption, it is 4.2 currently, and it's coming down from 4.3 per capita, and probably this reduction because of the 30% of our patients, they are on emicizumab. Starting 2026, we are starting marcizumab and probably Fioxaran. Thank you. I hand over the place now for Ahmed Khalifa and Dr. Hatoun.
Thank you so much. Before we move to the next session, just Dr. Ahmed, WFH. We need to say at least thank you. One more picture with my dear Kinga and Samiha before they head out. Okay, we left the best to the last. And I intended to do this because I know that lots of people will stay for this. So now it's the time really to appreciate and allow you to talk to people working really behind the scene. These people, there have been many years of wishes, and I speak instead of Ministry of Health, we always ask ourselves, we do policies, we do access to care, but we've never for a long time reached to patients directly. And without the work of the societies only, it wouldn't be possible. And I'm very happy that we have, honestly, great societies in the country. Alhamdulillah, we have a government that had built a good system for us. Lots of support, lots of human beings, whether doctors or not, working at a human being level. Since we started this, and things had enrolled and evolved very, very fast. So with the initiation of Mohja, that was born last year, 2025, in April, we managed to get the 5 patient societies in the kingdom, alhamdulillah, together. We've celebrated last year 3 amazing World Disease Days, the hemophilia, the thalassemia, the sickle cell, in 6 cities in the country, same time, same theme, same heart, same word, and without the dedication of the patient societies, it wouldn't be possible. So I asked Ahmed just to stay and not go down. So Ahmed Tarawa, do you have the names? Okay. So the first one, and we'll say the names in Arabic and English, is الجمعية السعودية لأمراض الدم الوراثية في المدينة المنورة, led by Professor Ahmed Tarawa.
Al Medina Hereditary Blood Disorders Charity Society. Yes.
And I'm not saying things by order, so maybe we started Al Medina, we will go down to Jeddah. So الجمعية السعودية لأمراض الثلاسيميا وفقر الدم المنجلي في جدة بروفيسور سلوى هنداوي.
Saudi Friends of Thalassemia and Sickle Cell Anemia Society, Prof. Salwa Hindawi.
Since we're on the west coast, we'll go down to Jizan. جمعية شريان لأمراض الدم الوراثية في منطقة جيزان أستاذ خالد الدبيان.
Hematological Patients Care Association in Jazan, Shiryan, Mr. Khalid Dubayan.
And we'll go back from the bottom to top, so south to north, but moving to the west coast. جمعية القطيف لأمراض الدم الوراثية دكتور محمد درويش.
Qatif Society for Inherited Blood Disorders, Dr. Muhammad Darwish.
And last but not least, our friend in Hessa, جمعية أمراض الدم الوراثية في الأحساء, دكتور عبد العزيز العودة. And actually, he just earned his PhD on the same day that Mohja was born.
Al-Ahsa Association, Charity for Genetic Blood Disorders.
I'm giving up.
Take this opportunity since all the societies that I may ask to give us few words about the societies, and then I would love to have some questions to them, some discussion. So please, إيش حنبدأ? Yes, Professor Salwa, since females first. أحمد عشان بده يمشي. طيب يلا.
Thank you, Prof. Izzet. Thank you, Prof. Salwa, because I have a flight and my car waiting outside, so I'm going to start, and then I will leave before them. So I'll talk about Medina Blood Disorder, Hereditary Blood Disorder Association, which has been established 18 years ago. And when I need to choose something to talk about in Medina, in 2 minutes, I'll choose one achievement we have made, which is sickle cell anemia free Khyber. This project, we were working on it for the last 15 years. And for the last 5 years, we have 0 newborn with sickle cell anemia. And I believe that this achievement didn't come except with hard working with the people in Khyber and the understanding of the people of Khyber. One of the projects which I do like myself, that Bina al-Taqat, which is you know, that hereditary blood disorder patient, they don't have enough challenges to challenge the people in the universities and so on. So that many of them, they cannot go for the governmental universities, so the association take care of those people in the private sector for those patients. The other one is the charity clinic for those whom they have no insurance, and support the hereditary blood disorder centers in Medina, where we have 3 centers, the one for children in maternity hospital, the one for adult in King Fahd Hospital, and the one in Khyber. So we do support those centers from many aspects there is no time to talk about. The other one, which is psychosocial support for the patient through campaign travels. We have gone to Al-Ula a month ago, 3 days trip where we have a psychosocial people to talk to those patients and so on. And there is so many programs we have, but they said that it's only 2 minutes. So I'll stop here and I give the mic to Salwa. Forgive me, I need to leave. My driver is calling.
Thank you, Dr. Ahmed. Bismillah ar-Rahman ar-Rahim. Good afternoon, everyone. I am so glad to be with all of you here today and to represent the Saudi Society of Friends of Thalassemia and Sickle Cell Anemia, which is in the western region of the country, and it is covering Makkah region. Our society is the oldest society in the kingdom. It's registered since 23 years ago. And we were working before even registry, 10 years before registry. We started it as the social things. But the society, since it's just registered as national society in the western region, it is supporting patients in that region. We were supporting patients everywhere in the country at the start as the only society. Then we concentrate on our patients on the western region. Our patients, we are giving them social supports and clinical supports, and we are trying to help them in whatever we as a society can help and do. We are pleased to announce that last year we had two important things done with the patient. We had one patient who get to the fertility project, and she had pre-implantation of ova, and she had a baby, new baby, which has no disease, and this was a great event for the family that they have a healthy baby, a girl. And this was with the support of the society, and it was excellent move. We are trying to do things, but it's because of the expense, we are trying to help one by one. And the other things, we already help one patient to have gene editing, and the lady this girl is 12 years old, and by end of 2025, she had her gene editing in Riyadh, and she was now in the recovery period, and we hope that she is doing okay. These two things, it gives the hope to other patients in the society that we are moving towards improving things. And also we are doing support of patients. We do awareness education campaigns, and we do also scientific, every year scientific conference. And last 2 years we had this conference with TIF support, and it was an excellent help for, we do Patients Day, and we do also Healthcare Day for education and awareness. Also, we are very glad and pleased and honored to have Mohja with us, supporting us from Ministry of Health with the lead of Dr. Hatoun and Dr. Ahmed. They already last year starting with us celebrating the most important days for thalassemia and sickle cell anemia days and the international days, and it was successful events. And we are happy to collaborate all the time with Mohja and with Ministry of Health for patient support. With this, I thank you all to him.
أستاذ خالد جمعية شريان جازان.
السلام عليكم ورحمة الله وبركاته، مساء الخير جميعا. دكتور هاتون اسمحي لي أتكلم بالعربي إذا أي أحد يحتاج ترانزليشن ولا شيء. برضو رنا نسوي زي ما سوينا في تركيا المرة الماضية إذا أحد يحتاج أي ترانزليشن أو حاجة. أخوكم خالد بيان رئيس تنفيذي لجمعية شريان رعاية مرضى الدم. في الحقيقة جازان نواجه تحدي جدا كبير، كما تعرفون أنه أكبر منطقة موبوءة بأمراض الدم الوراثية، ولكن إحنا كجمعيات الصحية في السعودية تتشارك نفس الأهداف، نفس اللوائح، قد نختلف فقط في الأنشطة، ولكن أهدافنا واحدة، أن نسعى لرعاية مرضى أمراض الدم بالتعاون مع وزارة الصحة. فنحن في الجمعية نغطي سنويا ما يقارب 500 بيشنت نون سعودي بتكلفة ما تقارب 2 مليون ريال سعودي. كذلك بالنسبة للمرضى السعوديين نقدر نعمل لهم مواصلات من منازلهم إلى المستشفى ذهابا وإيابا. من أهم المشاريع اللي تخدم المرضى قائمين فيها في جمعية شريان هو موضوع السكن الخيري في إجراء عملية زراعة الخلايا الجذعية في مدينة الرياض. هذا المشروع المرضى الدم يحتاجوا من 3 إلى 4 أشهر للمعيشة في مدينة الرياض في بداية عملية الستيم سيل. فالجمعية سنويا نغطي ما يقارب 100 بيشنت يعني بتكلفة ما يقارب 1 مليون ريال سعودي. كذلك
ممكن نوقف هنا. So the first support Mr. Khalid Dubayan is talking about is covering tuition housing for 3 to 4 months for patients who are undergoing stem cell transplants, and they're doing 100 patients per year, more than 1 million Saudi riyal.
فيما يخص التوعية والأويرنس في تأهيل وتمكين مرضى الدم من أهم المشاريع والأهداف الاستراتيجية اللي لدينا في الجمعية، واللي زادها أهمية خلال السنة الماضية أو اللي قبل بالتعاون والاشتراك مع مبادرة مهجة تحت قيادة البروف هتون والدكتور أحمد. الحقيقة هذا الشيء حفزنا إحنا كجمعيات صحية إنه نتعاون نتشارك في نفس الأهداف للتوعية والتمكين. نعمل بنفس الأهداف في الجمعية، نمكن المريض، لكن بالتعاون مع الوزارة صار التمكين أكبر، وبإذن الله يعني حنستمر في هذا المجال ويكون تأهيل المريض هو كأولوية عندنا في الجمعية.
One of the enhanced strategic objectives of the society that got actually enhanced, especially after the collaboration with Mohja and Ministry of Health, is patient empowerment and caregivers empowerment.
آخر شيء عندنا هو مشروع التبرع بالدم. نعمل حملات التبرع بالدم لتوفير أكبر وحدات دم للمرضى في المستشفيات. كذلك نقوم ببناء مقرات تبرع بالدم. بدأنا في بناء مقر متكامل في مستشفى الأمير محمد بن ناصر، وحاليا في السنة هذه بإذن الله هدفنا حيكون في 3 مقرات في أماكن عامة في الحدائق العامة للتبرع بالدم في منطقة جازان.
So several campaigns for blood donation, and they've dedicated a blood donation unit inside one of the hospitals, Mohammed bin Nasser Hospital, and the plan this year is to initiate 3 more in several areas in Jazan.
هذا بشكل مختصر عن جمعية شريان، ويعطيكم ألف عافية.
How many patients do you have?
In society
society. Because society doesn't cover only Jizan. It covers the southern region.
جنوب.
Jizan, Khamis Mashayat, several cities in and Jizan is a region with multiple cities already. So there are tremendous number of patients. Actually, when we did the initial screening for the registry, before starting the registry, there are around 30,000 patients in the area.
دكتور النون سعودي عندنا 500 بيشنت سنويا، هذه اللي يحتاجوا تغطية، هذه اللي بس اللي احنا نقدر نغطيهم، في أكثر من كذا. نون سعودي.
أي non-Saudi more than 500 per year to be covered.
So we'll move on to Dr. Darwish for the Qatif Society of Inherited Blood Disorders.
I would like to thank you. Thanks, Prof. Hitoun, Dr. Ahmed, for the success of the summit. And I would like to thank all Society of Blood Disorder in the Kingdom regarding the raising awareness, education as a part of raising even the patient voice. Patient voice may be implemented through Ministry of Health, through Mohje and societies to build up a system that we will reach the goal as a partner with the patients. Now our activity, raising education, awareness, and I'm glad to say that Qatif is a rich area of sickle cell disease. We have around 14 to 15,000 sickle cell disease patients. Now regarding thalassemia, we have a lot of patients with alpha thalassemia. Now, regarding beta thalassemia, alhamdulillah, we achieve a good achievement in our area. We have less than 100 patients with beta thalassemia. Youngest patient, 6 years. So we have 0 patients with beta thalassemia, alhamdulillah. And those couples who are productive for beta thalassemia, we send them for BGD for selection of a healthy child. This is briefly about our society. And thank you, Dr. Hattoun.
Yes, and now we'll move to Dr. Abdulaziz Al-Ouda.
بسم الله الرحمن الرحيم والحمد لله مبرئ البرايا مجزل العطايا له جزيل الحمد وكريم التحايا في الجهر وفي الخفايا وأصلي وأسلم على من بعث بجميل الخصال وحسن السجايا نبي الرحمة المهداة محمد بن عبد الله صلى الله عليه وعلى آله وصحابته أجمعين. يطيب لي في نهاية حديث هذا المؤتمر نتقدم بخالص الشكر والتقدير والعرفان لمقام وزارة الصحة وعلى رأسهم معالي الوزير ومساعد الوزير، وللجهة التنفيذية سعادة الأستاذ الدكتور هتون عزت وللدكتور أحمد عزت ولجميع الجهاز التنفيذي والمنظم لهذا المؤتمر. فلكم خالص الشكر والتقدير وبطاقات الورود والزهور على هذا الكرنفال الجميل الذي نسعد بحضوره والمشاركة فيه. فيما يخص الجمعية الخيرية لمكافحة أمراض الدم الوراثية بالأحساء، لديها ما يقارب في سجلاتها أكثر من 3600 مريض، تسعى في رسالتها إلى أن تصل إلى بيئة إحسائية خالية من أمراض الدم الوراثية. تقدم خدماتها لجميع.
Dr. Abdulaziz, just to explain the numbers. So the numbers are everything he said. I will not be able to translate, except that the number of patients are around 3,600 patients in Hassa Society.
تقدم خدماتها لجميع المرضى الثلاسيميا وفقر الدم المنجلي والهيموفيليا، ولديها في حزمتها تقريبا تقدر مصروفاتها السنوية في البرامج لبرامج الجمعية ما يقارب 3 مليون ريال سنويا.
Annual expenses more than 3 million riyals per year.
محزمة برامج الخطة التشغيلية للبرامج الصحية والطبية، وهي تستغرق وتكلف تقريبا نصف ميزانية الجمعية. أيضا لديها برامج يعني المحزمة برامج طبية وبرامج توعوية وتثقيفية وبرامج اجتماعية ونفسية وبرامج التدريب والعمل المؤسسي.
There is a split in this budget around 50% between both the medical contribution of the budget, the medical programs, and anything that is related to the awareness and the education of the patients and supporting them. So 50% of the budget goes towards this direction and the rest is contributing towards awareness and education.
في البرامج الطبية نركز على برنامج إجراء العمليات الجراحية لمرضى فقر الدم المنجلي ومرضى الثلاسيميا في استبدال المفاصل الورك أو مفاصل الكتف أو ما إلى ذلك. أيضا لدينا عمليات الأسنان، ولدينا برنامج اختبار الأجنة للأبوين الذين لديهم احتمال إنجاب أطفال مصابين بأمراض الدم الوراثية. وفي الهيموفيليا أيضا لدينا تأمين.
Because mashallah you have a lot, so surgical operations, specifically joint replacements, dental operations, and PGD and testing.
أيضا لدينا في مرضى الهيموفيليا تأمين كل احتياجات المرضى من الخوذ. أيضا لدينا من توفير الإبر الخاصة، توفير الأدوية الطارئة.
Helmets, خوذ صح قلت؟ أي so helmets for the hemophilia patients. تفضل.
البرامج الاجتماعية والنفسية هي كثيرة في برامج الترفيهية والبرامج الزيارات وحضور المؤتمرات سواء الداخلية أو الخارجية.
Rehabilitation programs and sponsoring patients to attend conferences and meetings.
برامج التثقيف والتوعية تشمل التثقيف والتوعية في جولات على المرحلة الثانوية للمدارس وأيضا في الجامعات والكليات.
Yeah, so they're targeting university students as well as high school students for the education and awareness programs.
في برامج التدريب ما يخص التدريب والتأهيل للمرضى وأيضا أمهات المرضى، ولدينا أيضا تدريب المرضى لسوق العمل والمساعدة في تأمين الوظائف لهم مع القطاع الخاص.
Working on workforce and empowering patients and helping them to get into the work market.
شكرا، وفق الله الجميع وسدد الخطى وحقق المنى على طريق الخير دائما وأبدا بإذن الله سبحانه وتعالى نلتقي.
Thank you so much. So honestly, we went in depth with each society, and I could tell you that everything said across the four chairs here is implemented in each societies, and it has been done with tremendous amount of work. Thank you so much to everyone, but would like to honor each society and a small announcement that is coming out of Muhja as well. Prof. Salwa, جمعية Saudi Friends of Palestine. جمعية شريان جزان. قطيف سوسايتي جمعية القطيف. حسا سوسايتي دكتور العودة. A final picture for Muhja Joint Association. Since all the societies are here, can we put please the BDA announcement for Muhja? So we'd like to invite you for the upcoming 3 days with all of the societies. The World Hemophilia Day, inshallah, will be in April 18. The World Thalassemia Day will be on May 9, and the sickle cell will be in June 20, inshallah. It wouldn't be this time just in the 6 cities. We are expanding on more cities, inshallah. Do not forget the Muhja Film Award, the AI Film Award. Thank you so much. Before we conclude the summit, this summit wouldn't be possible without our sponsors, all of the pharmaceutical companies. I would like to extend my sincere thanks to them, as well as Smart Health Company who had organized this event.
والآن مع تكريم شركاء النجاح الراعي الرسمي للحفل نيوبريدج. اللاتينية استرازينيكا. الفئة البلاتينية JSK. الفئة الفضية سنوفي. Eyes up. نوفو
it's not the end yet. And I cannot really conclude, and I've actually decided in future summits and events, I'll start with honoring them at the beginning of the meeting, not at the end of the meeting. This is my team, and if I stay here standing and describing how much of a great team that I have, I can't give them what they deserve. Each one of them honestly holds a special place, not in my brain when I give orders, and they hold a special place in my heart. Last year, we used to have a WhatsApp group called BDA Business Group. But I decided to switch the name to BDA Family because we honestly became a family. I told them that I have 4 kids, but honestly I feel like I have 24 kids now. I've never had girls, but I have many girls now. Thank you from my heart, every single person, for their work, dedication, honesty, the love they give to me and to the administration, to the ministry, is just, I cannot describe it honestly. So I'm not gonna go in order, but Mr. Jasser Nawi, he's the PMO office. He's the one that when Dr. Abdul Ali sends the list each month of tasks that he gives to the offices, he kept really the BDA #1 in having always the green color. So we always go with green flags with Jasser. Dr. Ahmed Khalifa, again, I've talked maybe a lot, but you could tell that all of the amount of work that you're seeing today and over the past days is just undoable without this guy, so thank you so much. Mr. Khalid Al-Asaimi, he's a new joiner, only 4 months, but he had held the education part and training in such an amazing, marvelous way. Dr. Ibrahim Al-Ghamdi, he's the KPI manager, so he's the one who keeps you on track. If you're not on track, you will get a red. Just to mention today, I want to show Ibrahim specifically my sportsmanship attitude. So his team won my son's team last night, and that's why I have his team's color today, which is blue and yellow, Al-Nasr. Mr. Mish'al Al-Shihri, so Mr. Mish'al Al-Shihri, I call him my back. I called him my back because Mr. Mish'al Al-Shihri is the one who has been with the administration for so many years. In spite of all the obstacles, the challenges, he never gave up and he stood behind my back. Dr. Saeed Al-Qahtani, the cutest, most amazing, charming person in the team. He is managing all the protocols that we published, and there are many to publish as well. Thank you, Dr. Saeed. Ustad Khalid Al-Asmari. So, Ustad Khalid Al-Asmari, I wouldn't really say what is he responsible about in the department because it's a bit sensitive, but he's the one who's keeping me on track. Thank you, Khalid. Ustad Hamza Al-Jahdali, he's the legal office, so he will bug you a lot, WFH and TIF, but he's the one behind all the MOUs, collaborations with national, international entities. Thank you, Mr. Hamza. Dr. Khadir Al-Barrad, he's another new joiner, only 4 months ago, but you look at him and you think that he's the most serious person in this world, but you cannot imagine how much of a cheerful person, dedicated. He always cheer you with his best smile in the morning, and even at 9 p.m. when we leave the ministry. Thank you, Khair. Dr. Salha Al-Utaibi. Dr. Salha Al-Utaibi has been dedicating really her time to work on protocol, but she had done an amazing, tremendous amount of work with the iron deficiency anemia project that Professor Farja had presented yesterday. Thank you, Dr. Salha. By the way, in regards to the consensus, we finished editing and putting stuff and deleting stuff until Wednesday, 9 p.m. And she's the one who stayed behind for this. Thank you, Salha. Miss Dima Al-Kathiri is honestly another kind of person. So Dima manages the human resources. Sometimes I feel her that she's a very close friend, and sometimes I feel her that she's my boss. Thank you, Dima. Miss Nawal Al-Utaibi, another new joiner 4 months ago, but all the audio of the 20 patients outside that you've heard, the 20 patients ambassadors, this is what Miss Nawal does day and night. She merged into Mohja and she just carried the whole project on her shoulders. I can't describe how much of a work she had done and how much of a relationship she had established in no time with those patients and families. Yesterday I went out and I found a mother with a patient with sickle cell, and the patient did not want to take the photo with her mother. She wanted to take the photo with Nawal. Thank you, Nawal. Miss Asma Al-Aqidi, another sweet, quiet person, but with the quietness, and she doesn't come to me. Mr. Hamza always comes to me saying, these videos and educational material, they're done by Asma. So thank you so much. Miss Lina Tasji. Miss Lina Tasji is the ITAI champion. She has an abstract outside, maybe you looked at it, and she's the publication data analysis machine. But Lina, our main office is in Riyadh. We have a small office in Jeddah, and I'm lucky to have Lina next to me. When she comes to the office to talk to me, she said 5 minutes, and it will be 3 hours unless you kick her out of the office. Thank you, Lina. Last but not least, my sweetheart Faiza Ahmed. So, Faiza is the marketing communication lead in the office, in the department, but at the same time, she manages all my appointments. So if you're having trouble with reaching me, Faiza is there, to an extent that she could text me at 1 a.m. and she said, you have a meeting tomorrow at 9 a.m. So do you want me to delay it and you will have an hour of sleep, for example? Take care of yourself. Did you eat? Thank you, Faiza. Now the team can't go with mentioning 3 more people. There are a lot, honestly, and everyone here had contributed. But since we started the newborn screening project, Dr. Faiz Al-Shehri, our pediatric hematologist in Khamis Mushat, had taken this project very seriously. He's doing all the newborn screening clinics in the kingdom. And with his great nurse practitioner, Ms. Najwa Kirari, who had to leave and catch her flight. And last but not least, Ahmed Al-Dosari. You are part of our team, so please come to the stage. Our ambassador for Mohja. Thank you for sticking around till this moment. It's very hard to say goodbye, but I'm very sure that we will meet again, and this is our final video for the day. Thank you so much.
Thank you so much. See you tomorrow, sharp at 9.